very good afternoon to one and all.
Afternoon.
Yeah, this is, we are having a webinar on violence against women that is labeled as Dheera by our own president, Foxy, Dr. Shanta Kumari. Dr. Shanta Kumari is the 60th president of Federation of Obstetrics and Gynecology of India, and she is known for developing something new. And what she thinks she is always ready to do, and she get it done. I can say she's an iron lady with her very good dreams, and her dreams always comes true because she works by action. So I welcome Dr. Shanta Kumari Madam for this program. We know that the violence against women, it's the one thing which we doesn't feel good when we talk about that. Why the violence against women? We are in India, in a land where it is said, यत् नार्यस्तु पूज्यन्ते रमन्ते तत्र देवता, यानी कि जहां स्त्रियों की पूजा होती है वहां देवता निवास करते हैं, जहां उनका सम्मान नहीं होता समस्त कार्य निष्फल हो जाते हैं। लेकिन शायद ये शब्द शास्त्रों तक ही सीमित रह चुके हैं, और यही विजन था जिसके लिए डॉक्टर शांता कुमारी हैज टेकन दिस लीडिंग रोल टू स्टार्ट द प्रोग्राम with the motive to stop violence against women, with the name as Dheera program. Today, when the women is leading in the world in many areas, still the women are still not safe walking on the roads, and they have a fear when they walk on the road. So it is the dream of the Foxy president, Dr. Shanta Kumari. She believes that when every woman can walk in the roads without any fear, then we will call the India is independence, and that is a true independence for the women. Realizing this fact, Dr. Shanta has started the program, and now I am thankful to Dr. Shanta Kumari for giving this opportunity to All India Institute of AIIMS Raipur to organize this program. And I think this is the first program which started at AIIMS Raipur, and this is a go long ahead with the all over society and all over the India. So I will be just taking some time to share my presentation. I'm just sharing my presentation to introduce the So I welcome Dr. Shanta Kumari to this program. She is the president of Foxy International Federation of Obstetrics and Gynecological Society. She is from Hyderabad, and she has lots of contribution to the Foxy in the form of chairperson of Indian College of Obstetrics and Gynecology, member of the FIGO working group, IIG managing committee, secretary, TCO, and her awards and achievements is I just can't count because it is a short program. Madam, I know that you are very well known personality, not only
Thank you,
in India.
Sarita, for your kind words. Shall we start the program?
Yeah, and welcome, madam. It is in a digital program, so we are doing the floral welcome to you. And then I welcome Dr. Nitin M. Nagarkar, sir, who is the director and CEO of the AIIMS Raipur, who has really kindly consented to organize this program under the umbrella of AIIMS Raipur, a person who is always there to support us in whatever program we are doing. So Dr. Nagarkar, sir, is busy right now in the OT doing one maxillofacial surgery, so he may not be able to join. Let me welcome Dr. Meera Baghel. She is the Chief Medical and the Health Officer of Raipur, and she is very well known and always on the papers with her contribution toward everything super story of super women. She is a super woman, and she works a lot in the COVID times. I think I have a very good friendship with her when we are working together in the COVID. Maybe it be in COVID, or it may be in a diarrhea program, maybe in a cholera program. She's always walking all over, and she's always there, and she believes on work is her passion. So welcome Dr. Meera Baghel madam to this program, and Dr. Ajay Bhardwaj, who is the coordinator for this program Dheera, and he has taken a way forward to conduct this program all over the country through the Foxy Society. Welcome, Dr. Ajay Bhardwaj, sir. This is again a floral welcome for you, Dr. Ajay Bhardwaj. I think you are listening to me. And my co-convener with me is Dr. Pushpavati. She's an additional professor of Department of Gynae, AIMS Raipur. I welcome Dr. Pushpavati also for this program. And because it is in a virtual program, I welcome you for the virtual inauguration. And I request all the dignitaries, Dr. Shanta Kumari, Dr. Meera Baghel, Director AIMS Raipur, and Dr. Ajay Bhardwaj to please bless this occasion with the formal digital inauguration. So thank you, the dignitaries, for blessing this occasion. Now I request Dr. Shanta Kumari and invite as a chief guest to address the occasion. Dr.
Thank you,
Shanta
Dr. Sarita, for your kind words. And good afternoon to all my colleagues, friends from Raipur who have joined this Dheera course, which is organized by the Raipur AIMS Medical College. Yeah, it is indeed so very I think heartwarming to note that all the Foxy members are so motivated to do this Dheera No to Violence Against Women, because we know the violence against women has an effect on women's health. And what we are trying to do is we try to sensitize everyone so that this violence against women reduces, so that the women are more healthier. That is our target, because as gynecologists, we are taking care of women's health. So that is the reason why we are doing this Dheera. And I have with us our friend Ajay is there, and all the other faculty, Dr. Padmaja, Dr. Lakshmi, and Prema Priya, Nandini, and others, Archana Kumari, who have joined us. You all know this Dheera online school certification program is being done with a collaboration with UNICEF India. This is to sensitize the boys and girls from the young age so that they grow up to be more gender neutral citizens of the country. And I want all the members of Foxy, my 39,000 plus members, to get tuned to it, to get sensitized to this Dheera No to Violence Against Women, so that in your day-to-day practice, when you take care of women's health, you will be able to be as a source of support to the patients, women who come to you for treatment. Thank you very much. And thank you, Sarita, for initiating this. And what I would request is, after this program is there, we are looking at the Dheera online school certification course. So please try to do this course in as many schools as possible in Raipur and Chhattisgarh and any other place. You may know some school in Delhi also you can do, Sarita. You can do in Tamil Nadu also. Do it, but so
yes, madam. And your
you.
leadership will definitely do it. And I still remember your presidential speech. If you give me 1 second time, I'll just read that your presidential speech, which I like the most. I wanted to become something special in my life and to make a difference. I believe that if I desire something wholeheartedly, there is positive power which makes it to happen. And Dr. Shanta, you really made it to happen to stop the violence against women. And definitely in the future, the violence against women may not be stopped, but of course it is going to reduce to a greater extent, and your goal will be achieved. Thank you, madam, for being with us. Now I will request, thank you so much, madam, for sparing your precious time. I missed you in the last webinar. Thank you so much, madam. Now I will request Dr. Meera Baghel as a guest of honor to please address the occasion with your thought of belief, how you lead on a life to improve the women's health. Dr. Meera Baghel, please, are you there?
Yes, Dr. Sarita.
Yes,
but
madam.
I'm sorry, I couldn't hear anything because of meetings and all other things and people who are coming. So I would like to hear from your guest speakers. And
Madam, you are very much audible. You please give an address.
Sarita, it is better to continue from the speakers, and then I will give my opinion in the last.
Okay, thank you so
Okay.
much, madam. Thank you so much. Dr. Ajay Bhardwaj, you're most welcome for your address.
Thank you, Sarita. We are already quite running late, but just in a one-liner, Dheera means courageous, and we all need to be courageous together. The Dheera program has started in the school, and this program particularly is for the fellow obstetricians and gynecologists. The reason for that is that you and the nursing staff are the first contact points whenever a woman in distress or affected by violence reaches you. And therefore, it is critical that each one of you not just understand and reiterate all that you have already been using and doing over the period of your practices over the several years. It's important that you take the lead. And more importantly, not only just understanding that you need to attend as a service provider, but also to attend and understand your own self. What do you do yourself to de-stress? How do you, as service provider, take care of yourself, because you need to put yourself first? And lastly, what are the various tools and guidelines available to you in a synthesized form will be presented to you in today's training program and workshop over here, so that you are fully aware as a service provider what needs to be done and how we need to move forward. Thank you very much, Sarita, for giving
you,
this opportunity once again. And 3 cheers to Raipur team, the AIMS team, because you are the first one who has started this initiative in the entire country after the master training session. So
thank you, sir. Thank you so much, sir. जहां रहेगा रोशनी लुटाएगा, किसी चिराग का अपना मकान नहीं होता. This word fits exactly same true for Dr. Ajay Bhardwaj, sir. I just missed the lines for Dr. Shanta Kumari. Madam, I just want to put it now. ना सूरज का इंतजार किया, ना सूरज का इंतजार किया, ना चिड़ियों का आह्वान किया. हमने तो आंख खोली लग गए काम पे, हमने तो आंख खोली लग गए काम पे, लो देखो सवेरा हो गया. और ये वायलेंस अगेंस्ट वुमेन का सवेरा, मैडम डॉक्टर शांता कुमारी इज द ओनली हैज एन विजन. So thank you so much for this, and without much ado we will go for the first session. And I think Dr. Ajay, you will permit me to start the scientific session and invite the chairperson for the first session.
Yes, please. Start, please.
So we are starting the first session. I take an opportunity to invite the chairperson for the first session, Dr. Sushma Verma. She is working as a director and consultant at Sarvodaya Hospital and Test Tube Baby, Raipur. And she's a consultant in Ayushman Endosurgery Center as well. And she's very well known for her work in the Indian Menopause Society as a Chhattisgarh chapter, worked a lot and took it to the heights. And she's I can say, an epitome in every field, and working not only in the IVF consultant, she's a great obstetrician as well. So I welcome Dr. Sushma Verma as a chairperson.
Thank you for your kind words.
Thank you. And the second chairperson for the session is Dr. Pushpavati. She's an additional professor of obstetrics and gynecology, AIMS Raipur. And the third chairperson is Mrs. Binu Matthews. She's a professor cum principal of Institute of College of Nursing, AIMS Raipur. I specifically involved the nursing college to be in this program because I know our nurses are working hard and they are being susceptible to this program, and almost 150 nursing college students are also joined in this program. So I welcome Dr. Binu Matthews as a chairperson. She worked with an internal inquiry committee of AIMS committee with me as a member secretary. So welcome Dr. Binu Matthews for this program, and I request the chairperson to take over for the scientific session and introduce the first speaker. I'm just after reading this, I will stop sharing, and the speaker, Dr. Padmajavi, can take over. Dr. Nandini can take over. Dr. Sushma, are you introducing Dr. Nandini?
Okay, ma'am. Okay. It's my proud privilege to introduce Dr. Nandini Babu. He is the consultant gynecologist, life member of Mumbai Obstetrician Society, life member of Vishar, Mumbai. and she's a life member of Vicarious Society, and she's a very renowned gynecologist, and she's the master trainer of Dheera School program, and she's the master trainer of Dheera of the Gynae program. Welcome, ma'am.
अरे ये कौन है मैं ये ले रही हूँ
Can share the screen, please? I stop sharing.
अभी से पोस्ट इसका मेरा नाम क्या है
Madam, you are muted, madam. Nandini, madam, you are muted.
Good afternoon, everyone.
Good afternoon, ma'am.
I sincerely thank Department of Obstetrics and Gynecology, AIMS, Raipur, to give me this opportunity to present Violence Against Women and overview.
Madam, can you please share the screen, or Sriman, you will be sharing the screen?
So, Violence Against Women is an initiative, Dheera initiative, which is started by Dr. Shanta Kumari, President of Federation of Obstetrics and Gynecological Societies of India. Next slide. I sincerely thank you to all those who helped collaborate on this project, Team Dheera, Obs and Gynec, core group, contributors to the presentation. Dr. Shanta Kumari, Dr. Kiranmay Devi Neni, Sir Ajay Bharadwaj, Dr. Vidya, Dr. Ramani Devi, Dr. Rakhi Dhawan Singh, Dr. Deepa Mukundan, Dr. Anita Sabarwal, Dr. Jyoti, Dr. Rohan Palshetkar, Dr. Krishnendu Gupta, and Dr. Aruna Suman. Gender-based violence is the most pervasive yet least visible human rights violation in the world. Put your responses in the chat box. What forms of gender-based violence are experienced as women and girls? Where can women and girls experience gender-based violence? Which age group may experience gender-based violence? Kindly write your responses in the chat box. What do we understand by violence against women? Violence against women means an act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. Violence, what are the types of violence? Violence against women encompasses but not be limited to physical, sexual, or psychological violence. It is seen in family, community, perpetrated or condoned by the state wherever it occurs. Types of violence can be physical violence, psychological violence, and sexual violence. In physical violence, when a patient comes to us, usually because of kicking, biting, slapping, beating, strangling. And psychological violence, preventing a woman from seeing family and friends, belittlement or humiliation, economic restrictions, violence or threats against cherished objects, other forms of controlling behaviors. And in sexual violence, forced sex using physical force, threats, intimidation, forced participation in degrading sexual acts, denial of the right to use contraceptives or measures to protect against sexually transmitted diseases. Next slide. This is the prevalence across the globe. It ranges from 25% to 40%. In Southeast Asia, it is 37.7%. In American region, it is 29 to 30%. It is prevalent across the globe, almost same percentage. Next slide. Intimate partner violence prevalence. In India, it is 28.8%. Highest it is seen in Bangladesh, which is 54.2%. And in Afghanistan, it is 50.8%. In Nepal, it is 25%, and 24.5% in Pakistan. And in Sri Lanka, it is 20.4%. Next slide. Gender-based violence is underreported. It is what you see is the tip of the iceberg. DHS survey data from 24 countries collected between 2004 to 2011, 40% of women experiencing gender-based violence previously disclosed to someone, but only 7% reported to a formal source. There is a regional variation, 2% in India and East Asia to 14% in Latin America and the Caribbean. Next slide. The cycle of abuse. It starts from pre-birth, infancy, girlhood, and adolescence. In pre-birth, we see sex-selective abortions, effects of battering on pregnancy and childbirth. In infancy, there is female infanticides, physical and sexual or psychological abuse. 20% of women experiencing child sexual abuse. In girlhood, child marriage, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, pornography. In adolescence, trafficking, honor killing, partner violence, marital rape, dowry, murders, abuse of women with disability, rape, sexual harassment, forced prostitution, pornography. Forced pregnancy, acid throwing, and date rape. Economically caused sex, incest, sexual abuse in the workplace. 20% of women experience child sexual abuse. Next slide.
Madam, shall I change the slide, madam?
Health impacts of gender-based violence on the individual. It could be physical or reproductive. In physical, acute physical or chronic physical. In acute physical, injury, shock, disease, infection, weight loss, gain, regressive behaviors, not eating or eating all the time. Chronic physical, disability, chronic pain, gastrointestinal disorders, eating disorders, sleep disorders, chronic fatigue. And in reproductive, miscarriages, unwanted pregnancy, unsafe abortion, sexually transmitted diseases, including HIV, menstrual disorders, pregnancy complication, and gynecological disorders. Next slide. Effects beyond the individual survival. Effect on children of women who experience abuse. Higher rates of infant mortality, behavior problems, anxiety, depression, attempted suicide, poor school performance, physical injury or health complaint, experiencing or perpetrating violence as adults. So when the person is in the childhood, whatever the person sees, what their parents are behaving, when the child becomes adult, so he learns and then the child starts acting like that. Effects on families, fractured family relationship, safe care, if abuse happened in the home, housing instability, co-occurring violence, poorer collective health and coping, effect on community and society, cost of services incurred by victims and families, health, social and justice, loss of education and potential development and contributions by child as they become an adult, perpetuation of violence in community, higher crime rates, burden on safety and justice sector. Next slide. Where and how do violence and HIV/AIDS intersect? Direct transmission through sexual violence, type of sexual exposure, presence of other sexually transmitted infections, degree of trauma. Indirect transmission, though sexual risk taking, violence is linked to increased risk taking, multiple partners, non-primary partners. Indirect transmission through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face of threat of violence. In summary, pathways and health effects. So intimate partner violence. There can be physical trauma, psychological trauma, stress or fear and control. In physical trauma, injury, musculoskeletal, soft tissue, genital trauma and others. In psychological trauma, stress, mental health problems, anxiety, depression, eating disorder, suicidal tendency. This all can lead to substance abuse, alcohol and other drugs, which can lead to non-communicable diseases like cardiovascular diseases and hypertension, and somatoforms like irritable bowel, chronic pain, chronic pelvic pain. Fear and control, limited sexual and reproductive control, lack of contraception, unsafe sex. And then which can have perinatal or maternal health problems, low birth weight, prematurity, pregnancy loss. Healthcare seeking, lack of autonomy, difficulty seeking care and other services. It can lead to sexual and reproductive health, unwanted pregnancy, abortion, HIV, and other sexually transmitted diseases and gynecological problems. Next. %42 of women who have experienced physical or sexual violence at the hands of partner have experienced injuries as a result. Mental health is twice as likely to experience with depression. Twice likely to have alcohol disorders. 16% to have low birth weight babies. Twice as likely to have an abortion. 1.5 times more likely to have HIV and contract syphilis infection, chlamydial and gonorrheal infections. 38% of murders of women globally were reported as being committed by the intimate partners. 4.5 times as likely to attempt suicide. Now quiz time. State whether myth or facts. You can write your responses, your valuable responses in the chat box. Intimate partner violence is more prevalent among poor women and girls, whether it is a myth or fact. Any responses?
we have equal number of people telling it's a myth and equal telling it is a fact.
It's a myth. Studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends. Next quiz. State whether myth or fact. In some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the wife is acting inappropriately, whether it is myth or fact. Please write your responses in the chat box.
So we have a near unanimous response that it is a myth.
It's a myth. Gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and the development of entire community. Other quiz. Majority of sexual violence against women and girls is perpetrated by strangers. Please write in the chat box whether it is a myth or fact.
We've had 2 people telling it is a fact. All the others have said it's a myth.
The answer is it is a myth. Studies constantly show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. One more quiz. State whether myth or fact. It is safer for a woman to leave a relationship with an abuser than to stay. Kindly write your responses in the chat box. It's a myth. Violence often continues and may even increase after a woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after separation. Thank you all for your responses in the chat box. Gender-based violence is a serious human rights, health, and developmental issue impacting survivors, their families, and the health and development of entire community. You have already done the registration and the pre-test. After the session, kindly write the post-test and the feedback. A link will be provided to you at the end in the chat box. Certificate will be awarded to participant on post attendance and submission of registration, pre-test, post-test, and the feedback. Thank you very much.
Thank you. Thank you, ma'am, for giving an overview about the violence against women. Your lecture was introducing a lot about this violence against, which is a neglected topic till date. Now, with the hope of this, this kind of the webinar, we at least reach to a majority of the people, and we will sensitize the individual for the violence against women. Thank you, ma'am. Now, I would like to introduce our next speaker. She's Dr. G. Prema Priya. She is currently working as Associate Professor, Vinayak Mission Medical College, Salem, Tamil Nadu. She is a recipient of the Best Poster Award U of Foxy and also a Best Paper Award in Foxy 2019 AICOG. She had conducted her fellowship in endogynecology in GM Hospital, Coimbatore. She had more than 12 publications in both national and international journals. She has presented various papers in the post-innovation national and international conferences. Her area of interest is adolescent gynecology. Dr. G. Prema Priya will speak on how to approach a woman facing the violence. Welcome, ma'am, for your topic.
Thank you, ma'am. Thank you for your kind introduction, ma'am. Thank you for the opportunity. I'll just share the slides, ma'am. Is my slide visible, ma'am?
Yes.
Yes, Prema Priya, you can go ahead. You're
So
visible, audible.
Thank you, ma'am. So how to approach a woman facing violence? I extend my thanks to Raki, ma'am, Kirmai, and Dr. Ajay, sir, for curating this PPT. And why do survivors not seek help? It is mainly because the victim-blaming attitudes of the providers, fear of shame, stigma, fear of no confidentiality, inappropriate services, or services that are not useful or prioritized by the survivor, perceived impunity of perpetrators. Any other reasons? Please write up in the chat box. So who can play a role to help the survivors and how? Everyone, including family, friends, community, service health care provider has a role to help the survivors. So coming to the role of family, friends, and community, recovery from violence dependent on extent of support received from the loved ones. Health professionals engage with family and discuss ways of promoting survivors' well-being. It should be discussed with all caregivers that survivors should not be held responsible for the assault. In case of child sexual abuse, parents may experience anger, confusion, guilt, self-blame. However, reiterate that it is a perpetrator who misused their position and not the parents. Coming to the role of healthcare providers, all women are likely to seek health services at some point in their lives. Healthcare providers are often trusted by women and serve as role models in the community. Violence is an underlying cause of injury and ill health. So, creating an enabling atmosphere and establishing trust is a main role of the healthcare provider. Speak to the survivor in a private space. Recognize her courage in reaching you as they have overcome several barriers. Recognize the dilemma faced by the survivor in reporting the violence. Do not label non-reporting to police as false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources or legal rights so that they can take an informed decision. Coming to the felicitation and demystification of medical procedures, the healthcare professional should prepare the survivor for an internal examination. Explain the various stages of examination, communicate the rationale for referral for X-ray, ultrasound, age estimation, amongst the others. So, how to address the survivor's emotional well-being? Recognize the survivors may present varied emotions. Encourage the survivors to express her feelings. Encourage survivors to seek crisis counseling. Assess for suicidal ideation. Make a safety assessment and safety plan. Involve family and friends in healing process of the survivor. So what you can say, take your time, share only what you'd like to share. I can imagine that you must have been really hard. How do you think we can help you? You are not alone. It takes a tremendous amount of strength to share what is happening to you. So there are some practical approaches while dealing with the survivor. One of that is solar approach. This includes sitting posture, leaning forward, eye contact, and relaxed. This is a life's approach in approaching the supporting the gender-based violence survivors. This includes listen, inquire, validate, enhance safety, and support. So learn to listen with your eyes, giving her your undivided attention, truly hearing her concerns with caring and loving heart. Use verbal and non-verbal means to show support and communicate understanding. Ask open-ended and focused questions rather than closed questions like yes or no. Use good body language, posture, eye contact. Avoid leading questions and compound questions. There are some do's and don'ts when you listen to the survivor. So, coming to the do's, be patient and calm. Let the client tell their story at their own pace. Let her know you are listening through verbal and non-verbal cues. For example, nod your head or say, Maintain gentle and appropriate eye contact. Acknowledge how she is feeling. Give her the opportunity to say what she wants. Ask, how can we help you? Encourage her to keep talking if she wishes. Ask, would you like to tell me more? There are some don'ts when you listen to the survivor. This includes don't pressure her to tell her the story. Don't look at your watch or speak too rapidly. Don't answer the telephone or look at the computer or write something else. Don't judge what she has or has not done, how she is feeling. Don't say, you shouldn't feel that way. You should feel lucky you survived. Don't assume that you know what is best for her. Don't interrupt. Wait until she has finished before asking the questions. And the other do's includes allow for silence. Give her the time to think. Stay focused on her experience and on offering the support. Acknowledge what she wants and respect her wishes. The don'ts are don't try to finish her thoughts for her. Don't tell her about someone else's story or talk about your own troubles. Don't think and act as if you must solve her problems for her. Coming to the inquire approach, it includes phrase your questions as invitation to speak. Ask always open-ended questions instead of closed questions like yes or no. Check your understanding by restating what she says. Reflect back to the client the feelings they express. Explore as needed. Ask for clarification if you don't really understand. Help her to identify and express her needs and concern. Sum up what she has expressed. Instead of asking what you say, you could phrase like, what would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or concerned about? You seem to be saying that. Validate does not mean try to verify the survivor story. For example, through the interviewing the alleged perpetrator or witnesses. This is not safe, appropriate, ethical, or recommended. Show that you understand and believe them. Tell them it's not your fault. You are not to blame. You did the most important thing you could do in that moment. If it is true, tell them that help is available. Otherwise, don't mention that. Tell them that no one deserves to be hit by their partner. Tell them you are not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. I'm worried that this may be affecting your health. It's okay to talk. Coming to the empathy versus sympathy. Sympathy is personal, emotional identification with survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. It is identifying with the survivor's experience through your own shoes. Empathy implies intellectual or personal understanding and realistic or professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. It is an attempt to put oneself in the survivor's shoes. So always, we must remember this boundary between the survivor and the healthcare provider. So life's approach we can use for dealing with the emergency situations. Coming to the challenging issues. When dealing with a survivor who is in immediate danger, if the survivor tells you that the abuser has threatened to harm them, what should you do? Please put your thoughts in the chat box. A few ideas are ask concrete questions about safety risk, but only when there is privacy. Ask if the survivor has a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave a situation safely. Provide a referral to your gender-based violence expert agency for additional help if possible. Remember, as a provider, it is not your sole responsibility. When a survivor experiences suicidality, be able to recognize the signs of depression and suicide risk. Don't be afraid to ask, are you having thoughts of suicide? If the answer is yes, take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult your supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to your gender-based violence expert agency for additional help if possible. Remember, as a provider, it is not your sole responsibility. Suppose if you ignore violence, it can do more harm. Here are some of the possible behaviors and the possible consequences. If we blame or disrespect the woman or girls, this will inflict additional emotional distress or trauma to them. If doesn't recognize gender-based violence behind chronic or recurring conditions, then the woman will receive inappropriate or inadequate medical care. If we fail to provide post-rape care or address gender-based violence in family planning or sexually transmitted infection or HIV care, this will lead to unwanted pregnancy, sexually transmitted infections, HIV, unsafe abortions, and even more violence. If we breach the privacy or confidentiality, then the partner or family member becomes more violent after overhearing the information. If the signs of fear or emotional distress are ignored, then the woman will later get injured or killed or commit suicide. So the doctor helped me feel better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house. The next time, my husband became violent. So be cautious when you ask the gender-based violence questions to the survivor. Remember that women are not responsible for men's violence. You may be his excuse, but you are never the reason for his violence. Warm referral practices help women reach further care. And these are some helplines, linkages. Suppose the survivor will reach out to someone that she trusts. It may be the family or friends or some community. Then they should be given the opportunity for medical examination, then psychosocial case management, such as follow-up, then protection, legal or justice, psychosocial and emotional support. So again, I would like to remind you that after the end of the session, please fill the post-test and feedback so that you'll receive the certificate. Thank you all for your patient listening.
Thank you, ma'am. A very good afternoon to all. Thank you, Prema ma'am, for sharing your valuable insight into how to approach a woman facing violence. As you rightly said, that we as healthcare providers have an important role to play in the life of women facing violence. We have to create an enabling atmosphere and help in this healing process. Thank you for emphasizing the mental health issues as well. I thank Dr. Sarita Agrawal, ma'am, Department of Obstetrics and Gynecology, AIMS Raipur, for organizing such a needed webinar in the present context. Thank you, ma'am. Next, I would like to introduce, thank you, ma'am. Next, I would like to introduce my next speaker, our distinguished speaker, Dr. Padmajavi. She is a patron member of Vijayawada OBG Society. She has held various positions as patron member of Vijayawada Obstetrics Society, founder, chairperson, chapter of ISAR AP, past president Vijayawada OBG Society, ex-secretary Epoch Society. So I welcome ma'am. She will be deliberating on the topic effects of violence against women on pregnancy and newborn. Welcome ma'am for your presentation.
Thank you for the kind words. I thank Raipur Society for giving me this opportunity. And of course, we're carrying on the vision of Dr. Shanta with the able help of Team Dheera, Mr. Ajay Bharadwaj, who has become a friend. We usually don't make friends later in life, but now you're a friend. And I thank Dr. Kiranmai Vindhya for putting together such a comprehensive slideshow on effects of violence against women on pregnancy and the newborn. And we will go ahead with this discussion. I don't know how many of you have really seen women in your OP who've been victim of violence or abuse. How do you think they present? Have you ever diagnosed it? And what are the most common clinical presentations where, if these warning signs are there, we should also have at the back of our mind, not just as doctors, not just as clinicians, not just the diagnosis at that point of time, could there be an underlying cause? So if you recollect any of these case scenes, do put up in the chat box. When we look at, all of us have been practicing obstetrics, we know that when we look at why mothers die, severe bleeding is the most common cause. Infections, eclampsia, obstructed labor, unsafe abortions, direct and indirect causes do contribute. The sad part is 90% of these maternal deaths are avoidable. Most happen in the postpartum period, 50 within 24 hours, and the reasons are 6 causes and 3 delays. But what we need to remember is there something else behind all these causes? And some of these unfortunate stories we hear of a woman who came out in Peru, who had bad obstetric history, loss of pregnancies. So what she told at the end of the story was, history was, he hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and the doctor could only clean me up. So what are, as obstetricians and gynecologists taking care of women, we need to keep this sort of scenario also in mind if we have an unexplained cause. Like, look at this lady who's a preemie with PROM, who was in prolonged labor, which was obstructed. She presented with rupture uterus shock, and unfortunately she died. Even in this era, women in pregnancy are dying. And when it was deeply probed, it was found that there was a history of brutal kicking in the abdomen. She was pushed violently, fall on a sharp edge, and that death was not an obstetric complication, it was due to violence. Another case scenario, Gravida 3 with 2 living issues at 28 weeks with previous 2 cesareans, came with APH shock and placenta accreta. We would rush to save her. The hysterectomy was done, 10 blood transfusions were given, bladder was involved, and what precipitated was the husband kicking it in the abdomen. Another case scenario, a woman who had a severe PET came unconscious, and eclampsia with stroke was what we thought led to the maternal mortality, and we labeled it as death due to eclampsia. But what actually happened was violence by the husband revealed as a post-mortem fracture in the skull, cerebral hemorrhage, and direct death is due to violence. So sometimes hidden violence masquerades as a maternal disorder. Look at this lady, where you can see, so when we are examining, not only are we going to just see the pulse BP, we need to have a look at her. You can see the healed, scarred fracture and the tummy. So she is Gravida 3 with 2 previous full-term cesareans. She had a implanted rod in the hip joint. She collapsed in front of a hotel where she was brought to 108. She was in active labor with severe hypertension. Because there was no other attendant, the consent of the resident medical officer said that and an emergency section was done. What was found out later is she was pushed from the 2nd floor 2 to 3 years back, and now she's in labor after 2 sections and she's been abandoned. This sort of unfortunate stories do continue. Look at this scenario where there is a Gravida 3 with 3, Para 2 with 2 dead issues, previous 2 cesareans, 36 weeks, severe anemia. Both times there is history of physical abuse, kicking in the abdomen, followed by lack of fetal movements. In the 3rd pregnancy, she could seek help. Her parents brought her home. She was transfused blood, and LSES was done with the live child. In this scenario, with previous 2 abortions, 2 cesareans, 3 induced abortions, acute hemorrhage, shock, sepsis because of an incomplete abortion. So forced abortions, emotional violence, physical violence, abandonment, all this sort of history can only be brought down when we do a screening. And she needed 4 transfusions. And you can see the amount of trauma that is there on the face. And the trauma on the abdomen was such that it led to a rupture of the uterus. So this was a stab injury by an inebriated husband with lacerations on the face, perforation of the uterus, intrauterine fetal death, needing a laparotomy and rent repair. So we are in a unique position because obstetrician gynecologists have a huge stake in women's health. We can assess, provide support for women who experience violence because they trust us. We have an opportunity to intervene, either, as was told by my previous speakers, in adolescent, pregnancy, family planning, annual checkup, or other health visits. At some point of time or the other, a woman will come back to our gynecologist. So what we need to do, if we are not comfortable, we see something out of the way, we can ask indirect questions like, is everything all right at home? Are you getting along with your partner? So that might be helpful. There are a huge number of screening tools, as you can see, the HARC screen, the HIT screen, the VAST screen, ongoing abuse screen. But in our daily practice, it is not so easy to be able to get these screening printouts and get all women to fill them. WHO in 2018 recommends that all health professionals be trained as first-line responses. And as Priya already said, listen, believe, inquire, validate, enhance their safety and offer ongoing support. So routine inquiry about intimate partner violence is not recommended, but in an ANC, we can look out for these. Most importantly, it is necessary to ensure safety, because we need to weigh, is there a benefit or there is a harm when our inquiry, and we don't do anything subsequently to help these women. So we need to ask them, women, about violence when it is safe to do so, when the partner is not present. And this needs to be followed up by an appropriate response for the women to help. I'm sure you've done your registration and pre-test. That's why you're able to attend. Do fill your post-test and give the feedback so that your certificate will be ready. Anasuya Sengupta said, women in many parts of the world speak the same language, the language of silence. So it is up to us as obstetricians and gynecologists, who are the primary caretakers of women, to be the voice of this silent victim. Thank you very much for listening. If you have any comments, please do let us know. We will have a look at that. And with the permission of the chairpersons, if any comments from the chairpersons.
Yes, ma'am. Thanks, Dr. Padmajavi ma'am, for very elaborate lecture and case discussion. They are really shocking cases that we came to know. The main objective of Dheera is to create awareness, advocacy, and sensitization of ourselves, our fraternity, victims, and male partners, and people at large. And to stop violence against women is the responsibility of each one of us. So, thanks a lot, ma'am, for your wonderful lecture. And we are actually the stakeholders of women's health and occupy the unique place in our society. So, we all have the responsibility towards providing quality care to our women, and we are the first point of contact for their health and emotional needs, and to provide support to all the women experiencing the violence. So, very wonderful lecture, ma'am. Thanks for the elaborate discussion and the case presentations. And I want to thank Dr. Shanta Kumari ma'am and Dr. Sarita ma'am for giving me the opportunity to be a part of such a wonderful webinar. And it is always a needed webinar because all the cases of violence against women are usually neglected and they are underreported. Thanks a lot, ma'am. And then I like to invite Dr. Sarita ma'am to proceed for the next session.
So I thank you, chairpersons, Dr. Pushpavati, Dr. Sushma Verma, and Dr. Beenu Matthews for being here with us and having the wonderful session. And speakers, Dr. Nandini, Dr. Padmajavi, and Dr. Priya. That's a great talk on that. Now we are moving toward the session 2. And I would like to invite the chairperson for the session 2 is Dr. Chandrasekhar. Dr. Chandrasekhar is an additional professor at AIIMS Raipur, and he has a special interest in the PPIUCT program, and he's in a great obstetrician. He can tackle any type of postpartum hemorrhage, has delivered talks and there's publications also. I invite Dr. Chandrasekhar as a chairperson. And the next chairperson for this is Dr. Vinya Mayaskar. She's a very good friend of mine, and we are the batchmate, did the obstetrics and gynecology together at Medical College Raipur. She's currently a consultant obstetrician gynecologist and the ART specialist at Sri Narayana Hospital Raipur. And she's a winner of the Foxy quiz, published many papers in the national journals and presented papers too. And she's a peer reviewer of the Jogi as well. And she's an author of the book on home care in the Parkinson's disease. That is a great achievement on her part. She inspired by her, because her father had a Parkinson's disease. She inspired that everybody who's suffering with the Parkinson's should not face the problem what she had faced. So Dr. Vinya Mayaskar has written a book on that. And the third chairperson for this is Mrs. Vahitha S. She's a lecturer in the nursing college, and she has an academic profile with a 19-year of teaching experience. And she's a research person for the Council JIPMED also. And she has guided on the 29th PG individual dissertations. She's an external examiners for many exams also. She's has more than 13 publications. And she's a Telugu guest lecturer in the AIIMS Bhopal. So I welcome Mrs. Vahitha S., Dr. Vinya Mayaskar, and Dr. Chandrasekhar to take over for the second session.
As Madam Padmajavi Madam has been already introduced, but she has sent us a very small CV, but her talks are not small, it's very big. So again, I am introducing her. She is a pattern member of Vijayawada Obs and Gynae Society, founder chairperson, chapter of ISAR, Andhra Pradesh, past president Vijayawada Obs Gynae Society, and ex-secretary Andhra Pradesh Obs and Gynae Society. Madam, I welcome you again for your talk.
Thank you. So if I have the permission of the chair, I will share this the screen.
Yeah, please go ahead and share the screen, madam.
We thank Dr. Ramani Devi, Dr. Deepa, Dr. Kiranmay, and Dr. Ajay Bharadwaj for these slides on mental health issues for women who suffer from violence. And this is an ongoing program of Dheera, which is the initiative of our dynamic president, Shanta Kumari, the visionary. And going on with how women come to us. So in this case, a 26-year-old woman was brought with sudden abdominal pain at 28 weeks of pregnancy. She was married for a year, and this is her first pregnancy. She was having regular antenatal checkups, but on examination, this usually very talkative, bouncy lady seemed very depressed. She was very quiet. Her vitals were stable. The uterus was 28 weeks. It was irritable a little. You can see sometimes those contractions on and off. The fetal heart was normal. Vaginal examination did not show anything. Then on inquiry, why she was looking so upset and what's causing that, she came up with the history of being beaten by her husband. So if we hear something like this, what are the details we need to gather? Do we need to inform the police? How do we talk to these women? And what are the problems these patients do come across? Do we need to call for a family counseling session? Can we give her any drugs for her depression? And what is the aftermath of this intimate part of violence? Please do put up your comments in the chat box. We'll have a review about what your thoughts are on this whole issue. So what we need is not just look after her pregnancy. We need to have a psychologist who will give her coping up skills, and maybe the opinion of a psychiatrist to make sure that this does not really affect her psyche. We all know that this lady needs mental health support, because the long-term consequences of this intimate partner violence is going in for a PTSD, and this syndrome was named for war veterans. So a woman who goes through this violence, her mental status is as bad as someone who returned from a war zone like in Iraq or Kargil or something like that. So sometimes they become hypervigilant, sometimes they have depression and suicide. All this can lead to substance abuse. There can be a sexual disorder triggered by that, some phobia. And sometimes they only tell us about recurrent GI symptoms like bloating sensation, inability to eat, lack of appetite, irritable, wanting to having a sensation of inadequate evacuation. So, or there can be sometimes dissociative symptoms, and sometimes they are socially withdrawn. So we as OB-GYNs who look after women for 9 months, so we know how they do, how they behave routinely. So it is up to us to pick up these. And the intervention role, what we need to do is first assess the risk, like any other, even in a pregnancy, we see low risk, high risk, like that. So assessment of risk, we are experts at it. What is the frequency? Is this, what is the severity? And is it a chronic ongoing problem of violence? And what can we do for her safety to prevent further assault? What is the psychological counseling that we can do? And most importantly, is she in danger? Is she having a suicidal tendency? Because suicide is a very impulsive and a momentary decision. If we can support her and get through that little hump, she will be fine. And also assess the domestic homicide risk. As our first speaker had told, intimate partner violence sometimes is associated even with this risk of homicide. So the danger signs, which are the red flag signs, like how we have for imminent eclampsia. So we know these danger signs for violence is if it is frequent, if there are severity of, if there are severe injuries, and alcohol misabuse. You could see how violent that man was just because he lost his control and has absolutely no respect for another life, especially when it is threatening to kill, when there is sexual violence, when the women have suicidal ideations, if there is an access to weapons always, and a morbidly jealous partner. These are the extreme danger signs. So we need to hospitalize whenever there are severe medical injuries, when there is suicide, or we think that she has a chance of being killed, when there are psychotic symptoms, when there is mood, total instability, self-destructive behaviors, and there is a serious threat to a woman's life. It's not, we can't cope about this alone. We are not alone responsible for this. So we need a teamwork, a multidisciplinary treatment, where the primary care of safety assessment, suicide and danger assessment is done, mood stabilization is done, medical evaluation is done, psychological support is there. And if they were subject to sexual violence, we need a rape kit, photo documentation, and a report to the legal authorities. NIMHANS has started this clinic. It's as a example in 2014, where multidisciplinary center with helps the survivors come to terms with the trauma, reclaim their lives by reducing the emotional symptoms of trauma, improve their self-reliance and esteem, provide a social support, and most importantly, prevent a re-traumatization. And awareness and capacity building program for the psychologists and counselors is also necessary so that they can support women. The impact of this is huge. It leads to women becoming helpless, loss of self-esteem and their confidence. At some point of time, they question themselves, am I doing something wrong? So that sensation of guilt. and they're so ashamed of the whole episode that they tend to isolate. In rare instances, they have paradoxical emotional tie with the perpetrator. So when we encourage them, why don't you leave? They say, no, I can't live without my partner. And as was told previously, if separation in the first few months, there is the highest risk of the woman being killed. And all this leads to a decreased ability of the victims to cope up on their own. And that is where we need to support them and involve their family. So a psychologist plays a main role in the treatment, where they do give post-assault psychotherapy with cognitive behavioral therapies, and where they're able to process this and decrease the fear and not be haunted by nightmares of continuous memories of the same event that happened. So what they need is, at that time, a briefly focused cognitive behavioral therapy, which will help them come out of this acute trauma and accelerate their recovery. So there are programs which called STARE, where there's a skills training in effective and interpersonal regulation. Education is done about trauma, its impact on the emotions, relationships, how they can effectively not inhibit from talk about their negative emotions, where their interpersonal skills are encouraged by appropriate assertiveness, and they need to have a flexibility regarding what are the expectations, actions, and reactions. So in this, we need to encourage women to also not be so unforgiving of themselves. We need to be able to accept ourselves. So IPT is interpersonal psychotherapy. It helps for PTSD, because many of these PTSD symptoms, they reflect interpersonal difficulties like emotional withdrawal from relationships and individuals, loneliness, and sometimes a hypervigilance. So as we were saying, cognitive processing therapy is also necessary, and through empowerment, they can overcome this, and relapse and prevention and relationship safety is also very, very important. So in women who have intimate partner violence, there can also be a depressive disorder, alcohol disorder. So they need mental health care. And this was what was recommended by WHO in the Intervention Guide 2010. So healthcare professionals understanding violence, they are the ones who need to look after women after they're through the process of their stress. So the recommendations looking into the role of antidepressants, they're not really necessary in mild or the initial phase, where support system and ability to listen to them and get them to talk about it itself helps. In severe depression, definitely they need tricyclic antidepressants or fluoxetine. And if there are prior depressive episodes, then they need to be on medication early. Usually 9 to 12 months, we need to continue the therapy after recovery. And not only medications, this interpersonal therapy, cognitive behavioral therapy are needed along with relaxation training. And there is no shortcut for physical exercise, because exercise is what improves the endorphins and our self-confidence the most. Psychological debriefing and first aid relief is absolutely necessary. Involving men in these therapies to take part, encouraging women to take responsibility for their violence behavior. So not just apologizing, taking an active measure to prevent it from happening. And they need to develop skills to react non-violently. Not every solution, every problem can be solved by violence. And we encouraging men in this group treatment will increase their awareness about the dynamics of the use of violence. So mental health is an issue in women affected with VAW, and it needs to be addressed along with the physical issues that we do see. And please do complete the post-test and feedback for your certificates. Any comments in the chat box, we can have a look. If not, the chairpersons, please.
Thank you, Madam, for it was a very elaborated talk. We should always know that we have to support the patient or any woman emotionally also, and not we don't have to work as a obstetrician and gynecologist. We have to have empathy towards them, and we have to sometimes we have to go for drug treatment also, relaxation, and lots of things have to be done. It was a very elaborate talk, ma'am. I invite uh, next person for his talk, ma'am.
I request Dr. Vinya to please introduce the next speaker, Dr. Lakshmi Srikhande. Dr. Vinya Mayaskar, please introduce Dr. Lakshmi Srikhande, the next speaker. Dr. Vinya, if you're not there, I can introduce Dr. Lakshmi Srikhande. Dr. Lakshmi Srikhande is a well-renowned gynecologist from Nagpur, and she is very well known in the Foxy. She was an ICOG chairperson as well, ICOG elect chairperson. She's a national corresponding editor for the Journal of Obstetrics and Gynecology of India. She's a national corresponding secretary, Association of Medical Women in India. She's the founder, patron of President ISOP of Vidarbha chapter and the chairperson of the IMS Education Committee from 21 to 23. And she has a long list of the posts she held in the Foxy and also in the ICOG. And my connection with her started when she was an HIV committee chairperson, and she took me as one of the member of her committee, and she did a wonderful work in the HIV committee, and the committee received the best committee award that year. And then she has work done on the field of Save the Girl Child also, and she was senior vice president of Foxy in 2012. I think there's a long list for Dr. Lakshmi Srikhande, but I know she's a lovely woman with always holding the hands of anyone who is a newcomer. And I can tell her as a woman who has really made my entry to the Foxy. With this words, I invite Dr. Lakshmi Srikhande for her talk on the topic challenging situations in the war and the self-care for the service providers. Madam, you are most welcome. Dr. Lakshmi Srikhande, madam. You can share the screen.
Yeah. Thank you so much, Sarita, for your generous words of introduction. It is always a pleasure to be associated with you. In fact, I am looking forward to meet you personally soon. So let us see when we can meet together. So it's a wonderful program which you have organized, Sarita. And the topic of my deliberation today is challenging situations in violence against women and self-care. So whenever we are dealing with a survivor who may be feeling hopeless, having suicidal thoughts, or in harm's way, what would you do? Remember, we all are OBGYNs, and one of your patients in your clinic tells you she's being threatened by her mother-in-law, which we all are very well versed with it. We all can relate with this situation. This mother-in-law is constantly pressurizing that she must divorce her husband because she is unable to have children. Our patient feels hopeless and she wants to give up. Will you do nothing or you would do something? So post your answers in a chat box that in this situation, what would you do? A few ideas just to help you, that be able to recognize signs of depression and suicide risk in your patient. Do not be afraid to ask, are you having thoughts of suicide? Because most of the times we do hesitate to ask this question. Do ask, and if the answer is yes, take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult a supervisor about how to refer or manage a suicidal survivor. This applies to if you are working in a corporate hospital, but if it's a standalone hospital and you are the owner, then we have to have a referral system. We have to contact the psychiatrist, the psychologist, and we have to take in consideration and involve her family as well. Remember, and on the other hand, you should not take decision on your own. This is for your own safety and well-being. You can give her the option, but let her decide and respect her decision. Provide a referral to a GBV expert agency. In many cities, including Nagpur, we have a one-stop solution centers. You can have those helpline numbers. You can give her those numbers for additional help. And if she wants to go there or call them, you should encourage her to do so. OBGYN should not ask survivors about suicidal thought or attempts. It could encourage suicidal attempts. This is a question for you all. This is true or false. Put your answer in the chat box that as a OBGYN, we should not ask a direct question about suicidal thought. True or false?
True. Chat कैसे करना है?
Chat में डालो. And just in the previous slide, I said that we do have to ask a direct question about the suicidal tendency.
True, na?
Those who are saying it is true is false. The answer is false. Asking about suicidal attempts or thoughts does not increase suicidal attempts. On the contrary, talking about these thoughts often reduces the woman's anxiety about suicidal thoughts and helps her feel understood. So once again, I am re-emphasizing that if you come across such a patient, please do inquire directly whether she feels like committing suicide or not. If the survivor tells you that their abuser has threatened to harm them, what should you do? Put your answers in the chat box. If your patient is telling you that their abuser has threatened to harm her, what should you do? Again, I am sharing few ideas. You can ask concrete questions about her safety risk, but only ask those questions when there is a privacy. Ask survivor if she has got a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave that situation safely. Provide a referral to an expert agency. Like I said, many cities, they have NGOs who helps us survivors, and mostly every city has got one-stop crisis center for additional help if possible. One of the most helpful techniques for helping a survivor to get out of an overly emotional state is to ask them close-ended questions that require them to think. Shift them from an emotional state to a cognitive state. These close-ended questions should require short answers, and do not return to your open-ended questions unless the survivor feels comfortable and has some degree of emotional control. So what are some examples of close-ended questions that you might go to in a situation like this? Put your ideas in the chat box. The examples of such close-ended questions are: how many kids do you have? Are they in school right now? What ages are they? We all have experienced this, that whenever we start talking about her kids, it really diverts her mind, and she, whatever be her emotional state, she does give you an answer. So what are the challenging issues when dealing with a survivor who may be mentally ill? So when you are facing such situation, state clearly who you are and what is your role. Be empathetic, non-threatening, and sincere in your intention to help. Give honest, factual answers whenever necessary. If you do not know, Say so that sorry, I don't have answer for your question right now. Do not belittle her concerns which the survivor raises. It is of great importance to her. Do not give advice as to the handling of her psychological problems. Attempt to be supportive in your comments and in your gestures. Do not assume mentally ill people that they should know better, or on the other hand, that they need to be told what to do. This assumption on your part is inappropriate. Be careful about making those assumptions, and you should know how to activate emergency mental health checkup in these situations. So additional challenging issues, you all can advise for the, you all can do the mediation in these cases. But what do you think? Can we really be part of this mediation process? Remember, mediation in these situations is not recommended as a response to gender-based violence. Also remember, health workers are part of a survivor-centered referral mechanism. The mediation process itself maintains and contributes to the abuser's ongoing power and control over a survivor. This is a very important sentence. The process of mediation presumes that both parties can speak freely, confidently, and safely. That is not the case. Mediation rarely results in an end to the abuser's violence, and it can actually lead to an increase in violence. It's unlikely that the survivor's right will be respected in cases of mediation. So the core safety precautions when you are dealing with these challenging issues or cases are: multiple people can handle difficulty better and more effectively than one person. So don't take on all the responsibilities on yourself. A service provider should never feel like that he or she must work alone with a survivor. A service provider should not work with both the perpetrator and the survivor, neither separately nor in the same interview. Keep the office door open of leaving the office or home if you are feeling unsafe. You have to establish a code, example, a code word with your co-workers to identify unsafe situations. Establish a relationship with your local police or with your local security agencies. Use buddy system at work, and to and from work, use to have a company. And if you are doing home visits, don't go alone. Use supervision to address security concerns. A group of people can address security more effectively than an individual. And I believe many of we do have our CCTV surveillance in our hospital, in our consulting rooms, and in our reception area. That also adds to our safety. Self-care for the provider, it is critical for you, no doubt about it. But do you know what is vicarious trauma? Put your comments in the chat box. I know we all have taken an oath that we have to provide care to our patients. It is very, very critical. But what about your own? What do you mean by vicarious trauma? I hope you all have put your comments in the chat box. Because you should be aware of vicarious trauma as a service provider for your own safety and self-care. So how to define this vicarious trauma? It is a change in a service provider's inner experience as a result of emotional engagement with survivors of trauma and hearing their stories. Many times we do get carried away by their emotional stories. The changes that occur in the service provider's physical, emotional, and or behavioral state as a result of constant exposure to these traumatic stories or events is called as vicarious trauma. So what are the causes of this vicarious trauma? The constant exposure to the stories of trauma, your desire to help or change the survivor's situation, feeling powerless when a service provider does not see positive changes in a survivor's situations, you overly identify with survivor, you think that as a service provider, you have the power to change a survivor's situation. So all these are causes of vicarious trauma. So how to prevent and manage this vicarious trauma? Here is the ABC of this. First and foremost, A is awareness. Being attuned to one's needs, limits, emotions, and resources. You have to practice self-acceptance. In short, you should know your limitations. Second is B is for balance. Balance, maintain balance amongst your activities, especially work, play, and rest. Third, C is for connection. Maintaining supporting relationships, communication is part of connection and breaks the silence of unacknowledged pain. These connections help prevent isolation and increase validation and hope. So this applies to you as a service provider, that you should be connected with your friends and families, and you should communicate your feelings with them. What are the self-care for the health provider? It is creating boundaries in the workplace. Don't go overboard. Don't get emotionally involved with the survivor. You have to establish support within the work environment, seek assistance from outside agencies, and create your own self-care plan, and you have to follow your self-care plans thoroughly. So now let us understand what do we mean by empathy and sympathy. So I want you to be involved during this slide. Pick up which statement describes sympathy and which statement describes empathy. You can post your response in the chat box. Statement 1 is a personal, emotional identification with a survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. This is statement 1. Statement 2 is an intellectual person understanding and realistic /professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. So which of these statement is empathy? Have you posted your response in the chat box? Which one of this statement is empathy? So why we are talking about empathy versus sympathy? It is to learn to create our own boundaries. Remember, sympathy is personal, emotional identification with a survivor's experience, and it implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement, and it can take power away from the survivor. So it is identifying with the survivor's experience through your own shoes. This is sympathy. Empathy implies intellectual /personal understanding and realistic /professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. So it is the attempt to put oneself in the survivor's shoes. So I hope now you all are clear what do we mean by sympathy and what do we mean by empathy. So how do you take care of yourself? Again, put your response in the chat box. Some relaxation and self-care techniques you all can use for your self-care of both physical, psychological, and emotional health. So remember, post-test and feedback is mandatory to earn your certificate. And if you are having any questions, I will be happy to answer those questions.
Well, madam, I think your talk was so clear that nobody has any question on that. Would chairperson like to say a few words on this talk, or we can proceed for the next lecture? Madam, thank you so much. You're really too good. Dr. Vaida, would you take the chance to introduce Dr. Prema again for the next lecture?
Yes, ma'am. Thank you. Good evening to all.
I think you're logged in through multiple devices. You please put off one device.
Thank you, ma'am.
Madam, turn the microphone off of any of the device.
Yes, sir. Yes, sir. Thank you, ma'am. Good evening to all. I take honor and privilege to welcome again Dr. G. Prema Priya Madam, Salem, Tamil Nadu. Already she was introduced by Madam. So I take again welcome you, ma'am, for second session's third topic, that is support system, rehabilitation, and resources for survivors. Welcome you, Madam.
Thank you, ma'am. Thank you. I'll share the slides. Is the slides visible, ma'am? Shall I proceed?
Yeah, it's visible. Please proceed, Dr. Prema.
So coming to the support systems and resources for survivors. So the overview of the section includes what are the protective laws and acts, what are the helplines, what is OSCCC, that is One-Stop Crisis Center, how can we link up and help in rehabilitation of the survivors. So the Protection of Women from Domestic Violence Act 2005. This act may be called Protection of Women from Domestic Violence Act 2005. It extends to the whole of India except the state of Jammu and Kashmir. So why Domestic Violence Act 2005? In 1983, the IPC 498A was there. It includes there is no emergency relief available to the victim. Remedies available were linked to matrimonial proceedings, and the court proceedings were always protracted, during which period the victim was invariably at the mercy of the abuser. Relationship outside marriage were not recognized. That comes the civil law, that is Domestic Violence Act 2005. In 498A, your husband is liable for punishment, but wife does not get any financial relief. But in Domestic Violence Act, wife or the female partner gets relief, but there is no punishment or arrest unless the husband violates a court order. Another difference is 498A can be booked against husband or his relatives, including the family. But Domestic Violence Act can be booked only against the male members of your family. So who can be a complaint? It can be a wife, a woman based on consanguinity, marriage, adoption, and cohabitation against a male abuser in a shared household. Can be a woman who is in a relationship similar to a marriage with a man. Technically, a transgender male to female could bring an action against a transgender female to male. A woman in a live-in relationship with an unmarried man, but not with a man who is married, if she knew or ought to have known that he was married. Anyone can file a petition with the survivor's consent. To whom can you complain? You can complain to protection officer, service providing center, or medical officer in charge, police station, or magistrate. Where can you complain? Jurisdiction under the Protection of Women from Domestic Violence Act includes where wife permanently or temporarily resides or carries on business or employed, or where the husband permanently or temporarily resides or carries on business or employed, or where the cause of action has arisen. The wife can choose any of these three options. Coming to the types of orders, it could be protection orders, stop violence orders, emergency relief, residence in shared household, irrespective of whether she has any right of ownership or lease, can request separate housing and abuser must provide. It could be a custody order, compensation order, violation of above order and offense, and magistrate can charge offense. Coming to the section 31, non-compliance of a protection order by magistrate can lead to issuance of non-bailable warrant. Coming to the time prescribed in this act, the act requires that all the proceedings brought under the act should be disposed of within 60 days of the first hearing, which must occur within 3 days following the application. The services offered include filing a detailed investigation report, providing direct complainant to a shelter, facilitate free legal services, provide counseling services as required. These are some of the domestic legal remedies in India, which includes the Fundamental Right, Article 14 on equality, National Commission for Women set up as a statutory body in January 1992 under the National Commission for Women Act 1990, Dowry Prohibition Act 498A IPC, and Protection of Women from Domestic Violence Act 2005. This is a one-stop crisis center which caters to immediate medical, legal, and psychological needs of women who are the survivors of physical, mental, psychological abuse, with the assurance that the consent and confidentiality will be respected and protected. At present, there are 234 one-stop crisis centers all over India, that is Shaki centers. The first center was started in Madhya Pradesh in 2014 June, that is at Gauravi, a joint initiative of the Department of Public Health and Family Welfare and Government of Madhya Pradesh, an action aid supported by the police department. Gauravi staff of 10 focuses on victims' need without compartmentalizing the services. Within 9 months of starting this, there are 9,500 complaints. And this is the Barossa Trust and She Team's office started in Hyderabad in 2016. And this is our own Shanta Kumari ma'am who started this. And all in one for violence against women with police, counselors, psychologists, legal advisor, and medical help at one center. The helpline is 100 and it will be directed to the Barossa if it's violence. A woman can walk in with the assurance that her consent and confidentiality will be respected and protected. This is a one-stop crisis center, that is Shaki Center, intended to support women affected by the violence. It could be from the family or community or workplace. And the type of abuse can be a physical, sexual, emotional, psychological, or economic abuse, irrespective of age, caste, culture, education, social status, etc. The main objective of this one-stop crisis center is to provide integrated support and assistance to women affected by violence and to facilitate either immediate, emergency, or non-emergency services. And this can include either medical services, such as providing medical treatment, forensic DNA test, legal services, police assistance, social welfare services, or psychological counseling, rehabilitation, and social reintegration services. And who to contact? These are some of the helpline numbers. 1091 is the All India Women's Helpline number for the woman in distress. 181 is a women's domestic abuse helpline. You can take the screenshot of other helpline numbers for Delhi. And these are the helpline numbers available for other states such as Andhra Pradesh, Arunachal Pradesh, Andaman and Nicobar Islands, Bihar. You could take the screenshot of these helpline numbers. And these are the helpline numbers for the state and union territories such as Daman and Diu, Chhattisgarh, Goa, Delhi. These are the helpline numbers that will get you to need in every state and union territory such as Gujarat, Himachal Pradesh, Jharkhand, Jammu and Kashmir, Karnataka, Kerala. These are the helpline numbers for Maharashtra, Mumbai, Manipur, Meghalaya, Mizoram, Nagaland. These are for Odisha, Puducherry, Punjab, Chandigarh, Haryana, Rajasthan. Helpline numbers. These are for Tamil Nadu, Telangana, Tripura, Uttar Pradesh. To take the screenshot of these helpline numbers and can share in your group so that it helps someone in need. And this is a helpline number for West Bengal. So again, I would like to remind you that at the end of this session, there will be post-its and feedback form. So once you fill, you will be awarded with your certificate. Thank you all.
Thank you, ma'am. Thank you, ma'am, for your valuable, rich and detailed information about support systems and the resources for survivors. Thank you, ma'am.
Thank you, ma'am. Thank you so much for the opportunity.
So I will thank the chairpersons for the session, Dr. Chandrasekhar, Dr. Vahida.
Madam, actually, there is one question I want to ask for.
Yeah, Dr. Chandrasekhar, please go ahead.
Yeah, actually, madam has provided lots of number and everything. Sometimes numbers are not working or there is some problem. So I want to ask one question, that there is any provision of online services that we can visit website and we can register kind of thing, because sometimes my numbers are busy and they are not working.
So mostly 100 will be working, sir. If you call to 100, then they'll be directing to 181 domestic violence, and you can reach the one-stop crisis number also, sir.
Okay, okay. So there is any provision of accessing all these things through internet or website or something? Okay, maybe later it will come. Okay.
That I'll check and tell you, sir.
Okay,
Yes, sir.
okay, okay.
Dr. Chandrasekhar, to answer your query, if it is a cyber crime, you can file online complaint for cyber crime. They have given, just type on the Google and you can file. There is no need to visit. But in case of domestic violence and other kinds of violence, what Dr. Prema has said, 100 and the national helpline number 1098. Plus, we do encourage all the participants to have the numbers of your local NGOs.
Okay.
The one-stop crisis center, have that number and pass on to the survivor and to your patients.
Actually, madam, why I ask this question? Because today is the era of apps and all those things. We are having Android apps, iOS apps. So I thought there may be some provision.
Yeah, as of now, we don't have. No.
Okay, ma'am. Okay, thank you, ma'am.
Thank
So
you,
once
sir.
again, thank you to the chairpersons for this wonderful session and moderating the session and the speakers. So we're proceeding for the third session, and the third session is again the speakers are Dr. Lakshmi Shrikhande, Dr. Archana Kumari, and I take this opportunity to invite the chairpersons for the same. And the chairperson is not other than a security officer of AIIMS Raipur, Dr. Mrs. Upasna K. Singh. She is an additional superintendent of police, Assam Police Department of Home, Ministry of Home and Government of Assam. She's been here at AIIMS Raipur on deputation. She's graduated from the Hindu College, Delhi, and the most proficient officer in the outdoor training she's been awarded with. And she has supervised training of the Special Female Command Unit and Assistant Commandant in Fort 10 Assam Police Battalion, and she has handed over many crimes related to sexual offences, POXO and domestic violence, and she is one and the only lady, I can say, in the part of the security officer which keeps all the security of AIIMS very strong. And whenever we have any sexual violence matter, or if there's a violence against women in any matter, she is one of the person who is always there to guide us how to go ahead in any committee activities. So welcome Dr. Mrs. Upasna K. Singh to this webinar with the all obstetrician and gynecologists. So you are not only the friend of mine, now the many of the obstetrician and gynecologists are going to be your friend. And I take this an opportunity to invite the next chairperson, Mrs. Chetna Sahu. She is again a nursing tutor, but has a bold vision on taking any violence against women. If there is something with either with the nursing student or the College of Nursing faculties, she is always there, and she worked a lot during the COVID times when we had certain issues related to violence in the women during the COVID time. And she's the one person who was standing behind to work on to solve the issues. So welcome Mrs. Chetna Sahu to this Foxy webinar on Dheera. And I ask the chairpersons to please take over for the further presentations. So, and introduce the Dr.
I'm already introduced.
Okay, madam.
But I would like to have the comments from Mrs. Upasna Singh and her experience before I start with my talk. Your comments first, and then I will start my talk on sexual thing. Yeah. Would love to hear your side. I think you are muted.
उनका वॉल्यूम लो है शायद आपके डिवाइस पे, वॉल्यूम हाई करिए।
Can you hear me now?
Not very nice voice. I think you are not on your speaker. You are just speaking on the phone.
हाँ, स्पीकर का कुछ कनेक्शन है।
Madam,
But
you
still
can,
you're audible. You can speak. I think we can listen to you, no?
madam, you can bring your microphone towards your mouth. It may be away from, yeah.
Yeah. So, ma'am, I am very happy at your presentation. I really like almost all the presentations. I could really make sense of the counseling sessions which Dr. Lakshmi ma'am has spoken about and Dr. Prema ma'am, because this is what, when we are trying to sensitize the cops, particularly at the lower levels, it becomes very difficult for us to make them understand that you should not be asking very triggering questions to the survivors. You should be more palliative in nature. So I found your sessions very helpful, and probably next time I go to the ground, I can speak to my juniors or subordinates about that. And that was a very really enriching experience. And so I would like to invite you once again, Dr. Lakshmi ma'am, and now we request you to please deliberate on sexual violence, how to approach women facing sexual violence. I'm really interested in this also.
Yeah. So thank you so much. But once again, after my talk, I would I'm definitely interested in having your comments. So this is from the perspective of the doctors. I mean, we gynecologists. So friends, here I am once again. The topic of my deliberation is sexual violence. How to approach a woman who is facing sexual violence. So for that, first and foremost, let us understand how sexual violence is defined. Remember, sexual violence refers to any sexual act or attempt to obtain a sexual act or unwanted sexual comments or acts to traffic that are directed against a person's sexuality using coercion by anyone, regardless of their relationship to the victim, in any setting, including at home and at work. So this is a very, very broad-based definition of sexual violence, and it includes sexual violence at home and at workplace both. Rape is the term that is commonly used for the first type of sexual violence mentioned, that is forced or coerced intercourse. That is a very, very crude version. But the WHO definition of sexual violence includes, but is not limited to rape, which is defined as physically forced or otherwise forced penetration of the vulva or anus using a penis, other body parts, or an object. So I know time is very short for me for this presentation, but I encourage all the participants to go and read the definition of rape. It is there in the Google. It is also a very broad definition, but WHO has modified this definition, and sexual violence is not only rape, but other types of sexual violence is also included in this WHO definition of sexual violence. So what are the facts about sexual violence? Chances are that you know someone who has been sexually assaulted. Victims usually know their assaulter. We all are taking adolescent health education program on the platform of Foxy in a big way. And we all have experienced that these adolescents or any woman most of the times faces sexual abuse from a known person rather than a stranger. Remember, victims are never at fault for a sexual assault. उसने छोटे कपड़े पहने हैं, रात को अकेले घर से बाहर गई है, तो इसका ये मतलब नहीं है कि victim is at fault. She is never at fault. Rape is the least reported and convicted violent crime in the world. And on this sentence, I would like to have Mrs. Upasana Singh's comments after my presentation. Sexual violence is preventable and help is available. That is the most important sentence of this slide, that help is available. So the forms and context of sexual violence. There is a wide range of sexually violent acts which can take place in different circumstances and different settings. Rape within marriage or a dating relationship. Remember, rape can occur inside a marriage also. Unwanted sexual advances or sexual harassment, including demanding sex in return of favors, is sexual violence. Rape by anybody is rape and it comes under the category of sexual violence. Sexual abuse of mentally or physically challenged person. Systematic rape during armed conflict and sexual abuse of children. These are just few examples of the sexually violent acts. Forced marriage or cohabitation, including the marriages of children, that is child marriages. Denial of the right to use contraceptive or to adopt other measures to protect against sexually transmitted diseases also comes under the category of sexual violence. Forced abortion is also sexual violence. Violence act against the sexual integrity of the woman, including female genital mutilation and obligatory inspections for virginity. This was a really fad a decade back, that before marriage, the boy's side used to inquire whether the bride is virgin or not. And female genital mutilation, though not very common in India, mostly it is common in the African countries, but it does happen in some parts of the India as well. Forced prostitution and trafficking of people for the purpose of sexual exploitation is also sexual violence. Marriage is often used to legitimize a range of forms of sexual violence against women, like marrying of young children, particularly girls, in many parts of the world, including in India, more so in the northern parts of our India. Child marriage, though is legal in many countries, but it is a form of sexual violence. Children involved are unable to give or withhold their consent for sexual act. Majority of them, they know very little or nothing about sex before they are married. So remember, child marriage is a form of sexual violence. So what are the consequences of sexual violence which we are worried as a gynecologist? It can result into pregnancy and the related complications, sexually transmitted diseases, mental, emotional health issues, suicidal behavior, and social ostracization. The fatal outcomes of this sexual violence can be in the form of suicide, homicide, or the patient can have AIDS, that is HIV/AIDS. Non-fatal outcomes related to sexual violence, the physical consequences are unwanted pregnancy, infertility. If she suffers from pelvic inflammatory diseases, that will lead to tubal factor, tubal blockage, and this woman can suffer from infertility in the long run. Sexual dysfunction, chronic pelvic pain, sexually transmitted infection, including HIV/AIDS, obesity or anorexia. Remember, eating disorders can be a part of a poor emotional health. Urinary tract infections, gastrointestinal disorders, gynecological and pregnancy-related complications, migraines and other frequent headaches, fatigue, nausea. The psychological consequences that come under the category of non-fatal consequences, outcomes of sexual violence are rape trauma syndrome, post-traumatic stress disorder, social phobias, shock, increased substance use or abuse, denial, fear, confusion, anxiety, guilt, depression, alienation, and eating disorders. So how to approach the survivors of sexual assault? Remember, sexual assault is one of the most invasive and intimate forms of violence. A trauma-informed care, that is TIC approach, should be utilized. This involves thorough understanding of neurological, biological, and psychological and social effects of trauma and violence on the individual. So when a patient presents and reports a sexual assault, triage the patient as a medical emergency. The immediate needs of a survivor of sexual assault are medical and or psychiatric evaluation and stabilization, activation of community advocacy to the bedside, mandated reporting as directed by the state statutes. We should encourage her for reporting of this crime to the appropriate authorities, offering and conducting, if desired by the survivor, the sexual assault forensic exam. Collaboration with law enforcement, if desired by the survivor, prophylactic medications for STI and STDs, pregnancy risk evaluation, care and safe discharge planning, and those providing medical and forensic care must always be prepared to provide testimony as either a fact and or as expert witness. So these are the immediate needs of the survivor. Application of trauma-informed care to the care of the patient that discloses sexual assault, the first and foremost is safety, trustworthiness, choice, collaboration, and empowerment. So let us first talk about the safety. Knock on the door and ask permission to enter the patient's room. Don't take it for granted and just go on in her room without knocking. Not allowed. Meet with the parents before she disrobes. Ask the patient to disrobe only when necessary or only partially disrobe. Provide and clearly identify the washrooms. Take time to familiarize the person with the physical environment. Ask about comfort level as far as lighting is concerned. Share control, show respect. Use a warm and compassionate manner to build rapport with the survivor. Now, the second issue is trustworthiness. Explain all procedures in terms the patient can understand. Tell the person what to expect and how long this all will take, and ask her what he or she wants. Third issue is choice. Ask her if you can touch them each time. Don't take it for granted that you can touch them here and there. Ask before you invite an additional staff in that room. Ask if you can close the door. Allow the person to decide where to sit in the room. Explain rationale for each procedure, what the procedure will feel like, and make appropriate modifications to reduce re-traumatization of the survivor. Obtain consent for each part of the exam performed. Fourth one is collaboration. Ask what are your top worries or concerns and address these first, if possible. Share information with the survivor. Encourage the person to make decisions about treatment. The fifth one is empowerment. Ask what happened to you, not what is wrong with you. So our words can make a lot of difference. Use your words cautiously. So ask what happened to you. Never ask why questions as they imply fault. So you should avoid the using of word why wherever possible. Take time with the person so he or she feels genuinely heard. Never be in a hurry. Ask if the person has preferences related to or has had difficulty with a particular procedure. Ask the person what you should know before you begin the procedure. Ask if there is a way you can make the procedure easier for him or her. Ask if there is a way you can make the person relax like a different position. Pay attention to body cues. Many survivors have been conditioned to be passive and defer to authority and so may not disclose distress during a procedure. And why I am using he or she? Because man can also be a subject of sexual violence. So either a man or a woman can come to you and can be a survivor of sexual assault. So what are the elements of this sexual assault history? First is, of course, medical history, recent consensual sexual activity, assault, which is related to medical history, sexual assault details should be inquired, nature of the physical assault, post-assault activities, and the suspect information. All these things you have to inquire in your history taking. So friends, this was in a nutshell what should be done, what should not be done when you are approaching a sexual assault survivor. Person can be a male or a female. In short, we have to be really compassionate. We should give them our time. Again, I am emphasizing that post-test and feedback is compulsory to earn your certificate. Now here, the floor is all there for Mrs. Upasna because I am sure she has not many inputs on this topic.
Ma'am, I was asking this. I was wondering, how often do you face the problem if the survivor has come to the police, then the process goes to police, we send the requisition to you, and then the process is done. How often do you face the problem that the person has come to you, confides on you, and do not want to report to the police?
I am a standalone, I mean, very small nursing home. So personally, I don't have any experience of these kind of cases. What you are inquiring?
Anyone can, I mean, anyone.
Yeah, any gynecologist who has got any experience, what she is asking. Because usually what you are saying is the norm, that they first go to the police and then they are brought for the examination to the doctor. Yes, Dr. Archana, you want to say something? Unmute.
Yes, actually, good evening, ma'am. Actually, I am in a medical college, so most of the time we get cases who already come with a police request, examine the patient and give the injury report, something like that. But we do get cases who come on their own. So in that case, we are supposed to inform the police, but again, it is up to the rape survivor's wishes. If she wishes, then only we can inform the police. But otherwise, we consider.
My question is a little more particular. Say on a scale of 10 cases, how many do you find that they do not want it to be reported to the police?
Most of the time they want it to be reported to the police, or most of the time they come, the cases come to us through police only. Because what happens, usually the places are in periphery. So their first aid is done and then they are referred to the higher center, and already police information is done there, and then they come with the actually police report only.
Madam, I have inquired 10 years back. I have encountered a case where a female was stabbed multiple times in hands and feet, and she came to me for do my MTP because I'm having bleeding per vagina. I thought that actually that was in private 10 to 12 years back. And then I was about to examine that patient, and I saw what are these deep hole kind of marks were there. Then I thought that it is. Then I actually realized that it is a stab marks. So lots of people were outside of the nursing home. They were pressuring me not to report, and even female, the patient was saying that I don't want to report to anybody because she was so much frightened. So I did at that time. I just said I won't do anything. Just go report to the police, and if there is FIR something will be filed, then I will go do something. Okay. That was the thing. I never did anything, and it came back.
Okay.
So what
Mrs. Upasna, I also want to give a comment of my own experience being in an institute. See, those cases were coming through police is not a problem. But those were coming to the routine, out of 3, the 2 doesn't want to report to the police. And I just want to share one of the case who had an injury in the vagina. She came with the bleeding PV. She was just an 11 years old girl. And then when we examined, we find it was in a classical tear of the forceful intercourse. But when she was inquired that she needs some police information, all the relatives, she was a minor, but the mother, the father, and nobody wanted it to be reported to the police. And then because she had a major injury, the patient was admitted, she was managed. but still they were not ready. But as a part of the duty of a doctor, we informed to the local police station, and then whatever they want to the police statement. I think this is a responsibility. If we feel it is an injury because of the sexual violence, we have to inform to the nearby. Then the police should do what they want, and whatever they want to continue with that. That is my
I
experience.
also came across a case of around 34 weeks pregnancy with trauma to the patient over the abdomen by the husband, and she came with a ruptured uterus with IUD. And she was not giving the history. When I asked the history of trauma, she told me that I will tell you, ma'am, but don't tell to others. And I don't want to repeat. Even after that, the patient is in danger, her life is in danger, her baby is already dead. Even then, patient is not willing to report against her husband. She thought it is a family matter, it should be inside the family.
So everyone present here, I would like to share something. Probably this would help you also. If anything of this sort comes to you, and you should know that the laws, particularly in our country, says that if the person has victim or the survivor has come, if she is not a juvenile, then what you must do is you must give a MLC report. The legal aspect, you have to inform the police. Now, informing the police is different from the victim filing an FIR, first information report. So you also can do one thing. This is the concept of informed consent or refusal to file an FIR. So please get it signed from the survivor or her parents that I just, since it is your duty to report to the police, so that you will have to do in any case. Other than that she is not willing to go ahead with an FIR should be signed by the survivor, her parents, any guardian or parents, and one independent witness, and be given to the police station. That way you are also in the safe. That is one way, that is the proper legal procedure to be followed.
I want to discuss one more case and just want to take your opinion. One of my patient of around 18 years, she came to me with a pregnancy of around 22 weeks, and she was repeatedly raped by her brother-in-law in her household.
Okay.
She came for MTP, but she did not want, even the father of the daughter did not want it. We should report in the police, and the patient is 18-year-old. And she doesn't want to report, then how should we proceed in such cases if the patient, we know she is a victim of rape, we know. So initially it was forceful.
Even in that case, which is the crime of rape according to section 376, we know that it is a crime of rape. But since she is not wanting to report it, the onus should not be on you. Otherwise, also, I am repeating, you will have to give the MLC report to the local police station that some case of this sort has come to light in front of you. It has come to your notice. And with that, you have to take the consent of the survivor or the victim and get it signed from her or guardian or parents, whoever there is present, and an independent witness. This concept is called the concept of informed refusal. That is, she knows you have given her the option that you can report it to the police. Now she is not obliging to that, or she is not wanting to do that. So you take her consent and go ahead and give the report to the police. So
and Dr. Sushma, I would like to add one more point in that. Is if you are suspecting a case of the sexual violence in any way, it is very, very important that your case sheet, you should make a complete injury report at that moment of the time, because if she reports later on, and if you fail to provide the report, then you can be liable for the hiding the evidences. So it is very important for you that you should have every detailed information on you.
What ma'am has said, this comes under section 92 of IPC. That is, you know that it's a heinous crime and there is threat to the person, then you should give the report in bona fide, in good faith, and you don't need the consent of anyone in those circumstances. You will be all safe.
Mrs. Upasna, I just want to share one more thing. Like we are talking, Dr. Lakshmi Srikanth has very well defined the sexual violence is not only a rape.
Yeah.
It is, we are having the sexual harassment part, and everybody of obstetrician, they do have the nursing homes, or they are working in the corporate hospital. So there is a Vishakha guidelines for that, for the sexual harassment at the workplace. So every institute or a corporate hospital, or whichever the employees number is, one is fixed, on that there should be an internal inquiry committee for that. And the Vishakha guidelines very well defined the who should be the member of the internal inquiry committee, how the report should be submitted, how the proceedings should go, and what will be the further actions on that. Then the role of the inquiry committee comes, and if it is a government institute, the disciplinary actions are being taken. So it is very, very important. And I think those who are having the corporate hospital, you have to look for it, whether you do have an internal complaint committee for the sexual harassment or not. And the Vishakha guidelines is very, very well available in all the websites. So I think you all should go, and it defines clearly. It is not only the physical contact, but even the sexual remarks, maybe verbal, non-verbal, maybe showing the pornography, and maybe just forming the colored remarks. There are so many five points are there. So they actually comes as a part of the sexual harassment, and we also have to be aware about that.
Yeah, Sarita ma'am has pointed out a very important thing. In fact, I would like to elaborate. If you give me a minute, I'll elaborate on this. Post 2012, after the Nirbhaya incident, that heinous crime, there were certain amendments made to the criminal law of the country, where the definition of rape, which is in section 376 of IPC, it was broadened, where it is not only penetration through the penis or penetration by the penis, but also by other means. So, for example, non-touch things like voyeurism. Voyeurism is like getting someone to force to pornography, or the other forms of sexual penetration, without the penis. They are also considered to be forms of rape. And in fact, it is only 3 days back that we have got a verdict from
your
the
voice
Delhi
is
High Court,
lost,
where the court says that there is something called digital rape. Now, digital rape has nothing to do with the online thing that we think that it has become very vicious, but it is it is regarding the forced penetration by fingers and toes done by a 80-year-old man. This is only 3 days back. So now we have a court-derived law also. They say that digital rape, which is not penetration by sexual organs, but by other means, also comes under the definition of rape. So that means we have broadened the definition of rape and sexual assault, which is outraging the modesty of women. And laterally, we have formed, as ma'am has said, we have laws to deal with sexual harassment at workplaces, and also POCSO, which deals with the sexual harassment cases of people who are below 18 years of age. So these are the laws in place. Now, I have one question to all of you.
Yeah, please.
Yeah. Actually, we since in these kind of cases, we are intersectoral stakeholders who come together to solve these problems. We have noticed, as cops, we have noticed that most of the time convictions do not take place when the substantive evidence is lost in the court cases. Now, we face problems in, probably a FSL person could have said better, but still you can guide us. What are the problems that you face when police people, cops, they pack or they send the evidence to the forensic laboratories? What are the difficulties that you find, you feel that they make? What are the common mistakes that the police make when they send evidences, swabs, vaginal swab, not vaginal swabs, they will pack the cloths and they will send it to the doctors. They will send the cluttered nails or whatever they find in the scene of crime to the forensic laboratory. So what are the common mistakes? क्योंकि generally हम लोग को बोला जाता है कि ऐसा आया है मैडम एविडेंस, वो जो specimen आया है तो उसको हम लोग ठीक से जांच नहीं कर पा रहे. This is the common reply. So what common mistakes we make that make it difficult for you to give us the results?
I think those who are doing these examinations, Archana, would you like to answer?
Yes,
the delay or what? I mean, I really appreciate, Upasna, your concern and a very, very valid question. Yeah. Yes, Archana.
There are so many swabs and the protocol which we have to follow, and this I will be discussing in my session also. How to collect evidence, sample collection is very difficult part. But most of the time, what I have seen, they are not willing to take the sample and sealed envelope और ये सब हम लोग खोजते रहते हैं. They are not willing actually. It is a pass on कि नहीं आप यहाँ भेज दो, आप वहाँ भेज दो. It's very difficult to hand it over to them. And of course, the protocol, it is to be sent in a sealed envelope, paper envelope, plastic clothes. Those things are not available to us most of the time. The kit is not available. We are also perplexed how to send the swab, how to send the combing. The whole kit is not available to us. I think this should be made available in medical college. I don't know about Sarita madam, what is in AIMS, whether the kit is available or not.
Yeah, I would definitely like to comment. It's a very important, when we talk about the delays that Dr. Lakshmi Khande madam was describing, the first delay is reporting by the patient. The second delay is this being brought to the police, to the institute by the police officer. By that time they reach, they have either taken the bath, they have washed the area, they have changed the clothes. And then when you are collecting the evidences, your evidences may not be right one.
Right.
Even the delays of 2 to 3 days are there. So that is what, these cases are actual, the rape cases, and the lack of the evidences, they are being escaped. So this is the thing that we have to fill up this lacuna. There's a proper, that is what an immediate reporting and immediate addressal of these issues is important. And the delays at the medical college and institute is always there. When the patient reaches over to the institute, there is a delay. Either the doctors are busy or the not assigned duties are there, who will perform this. So there are so many things for that. Now in AIMS that we have the forensic medicine department has taken care of this, and they are doing the excellent job. Whenever this type of survivors come, they are being immediately taken care of, and the resident from the institute or the consultant from the Department of Obgyn goes and does the examination. The final report is prepared by the forensic medicine people who are very well conversant with how to go ahead and how to deal with this police people also. And of course that they're now in, like when I was in the state medical college, we didn't have the facility to collect all these, and the things were not there with the proper label. But in AIMS, I think we do have everything where the things can be packed up, wrapped up properly and handed over to the police station. And we have the defined catering area also, which area we should work actually. So what happens, every peripheral center refers this patient to the medical college for the expert opinion. That is one which should not be entertained anyway, because everyone is expert on giving the report. You have to just define the injury report, that's all. And the medical officer should be there, and it is a responsibility of the medical officer posted in the peripheral center. They should know the basic formality, what should be done and how it should be done. That is the way I think we have to strengthen services which we really want to safeguard our women.
In all this, I would like to, if I'm sure you people must have gone through the directives of Ministry of Home Affairs, जो हम लोग का है, Parent Ministry, and otherwise your ministry, MOHFW, they have also come out with some very good directives and a book. So you people can go through that. They talk about very intersectoral stakeholders coming together, like the police, the judiciary, and the doctors coming together, and how they can, at least we can hope of increasing the conviction rate in rapes, where it is only 27. The conviction rate is actually 4%.
Yes.
Trial cases is about 27%. So it is very important that we come together and we do this. And I thank
Mrs. Upasana, you'll be happy to know that the FOXI has taken an initiative, and they are training each and every obstetrician and gynecologist how to do the examination of the survivors. And Dr. Archana is going to take care of to explain everything, and many of our obstetrician friends are waiting over to understand, do that. So we should proceed for the next session.
Madam, can I have a last question? Okay. I want to ask ma'am when to take the aids of photography and videography in this kind of injury cases.
Dr. Chandrasekhar, Dr. Archana is going to cover all these things, I think. These are the part, I think, what I have seen the everything on that. So let's invite Dr. Archana. Who is inviting Dr. Archana? I'm just sharing the screen to show her CV.
Okay, actually, I shared my screen.
Okay, that's why I'm not able to do that. Okay, Dr. Archana, if you have your CV slides, you can show, because you didn't allow me to show your CV. If someone has a CV,
I will stop sharing then. Madam, you can just speak with 1 or 2 words for me. That's okay.
Actually, you have to stop.
Okay.
If someone of the chairpersons read the screen presentation.
Yes, I have stopped sharing, ma'am. I have stopped.
Okay, then I'm sharing the screen. So Dr. Archana Kumari is an associate professor, Department of Obstetrics and Gynecology, RIMS Ranchi. She's a nodal officer for MDSR and MNM RIMS Ranchi also. She's a convener for the Clinical Research Committee, East Zone Coordinator for the Quiz Committee, and she has been examined for MD, MS and the DNB examination. And she has been awarded with the FICG, Vidya Basin Awards, Best Paper Awards, and lots of appreciation awards. And Dr. Archana is going to explain us about how to do the examination of these survivors when they visit to your institute. So with this, all Dr. Archana.
Thank you so much, ma'am, for your kind introduction. I must congratulate you for organizing this wonderful webinar. And I also want to thank Foxy President for her vision of training every Foxian in this endeavor of violence against women. And of course, Dr. Kiranmai and Dr. Vindhya also deserves a round of applause for putting so much effort in preparing these PowerPoint presentation and making things easier for us. So I'll be talking about examination of survivor and collection of evidence. What is the role of the gynecologist? We actually are very important to provide evidence of the crime, which help judges to understand the physical and mental condition of the survivor. And we also use the reports to corroborate the survivor story and enhance the credibility. And we also offer, of course, the primary level of counseling, treatment, and refer for any physical or psychological sequelae. So the medical examination will always start with taking an informed consent, recording the history. Injury documentation is so very important. And then, of course, the collection of evidence we will be discussing in detail in the subsequent slides. So overall, there are 25 things to do. And we'll be discussing it one by one. Point number 1 to 11 are the general instructions. 12 is informed consent. Then we have to document the mark of identification. We have to take the relevant medical and surgical history, history of sexual violence, type of physical violence, emotional blackmailing, all things we have to record. Then we have to do a general physical examination. We have to do a specific examination for any type of injuries present. Examination of external genitalia, systemic examination. Then the point number 20 and 21 is regarding the evidence and sample collection. Then we have to give a provisional medical opinion, treatment, what we are supposed to, of course, being a doctor and gynecologist, we have to provide the treatment. That is our first priority. And then the date and time of completion of the examination. And then after the reports are coming, we have to give the final opinion. So these are the general instruction. These are the pro forma where we have to document the name of the hospital, the OPD number, IPD number, name of the survivor, daughter, wife, son, or so and so, address. The age is to be reported, date of birth, sex, male or female, date and time of arrival in the hospital, date and time of commencement of the examination, brought by the survivor is brought by whom. Their name and signature should be documented. It is very important to take their signature as well, the MLC number, police station, whether the patient, whether the survivor came in conscious state or coherent, and whether there was any physical, intellectual, or psychosocial disability. So all these things we have to mention because interpreters and special educators will be needed where the survivor has special need, such as hearing defect or speech disability or intellectual or psychosocial disability. Many times we come across the survivor who are mentally challenged something. We do get these type of cases. Then this is the pro forma for the informed consent. I, daughter of so-and-so, hereby give consent for medical examination, yes or no. Medical legal examination, yes or no. Sample collection for clinical and forensic examination. I also understand that as per law, the hospital is required to inform the police, and this has been explained to me. I want the information to be revealed to the police, yes or no. Here also, this is what Upasana ma'am was emphasizing, that we have to inform the police. But again, to go ahead with the FIR, we have to take her, whether she wants to reveal information to be revealed to the police or not. And then I have, the survivor has to say that I have understood the purpose and procedure of doing my examination, including the risk and benefit. And this has been to explained to me. And at any time, I have right to refuse the examination, including my medical treatment. And my refusal has also been explained and may be recognized. And above thing has maybe, I think this is hindering a bit in my view. Actually, let me change the view actually. Anyway, it is not going. So the thing has been explained to me in local language, or whether special educator or interpreter has helped, then their name and signature is also to be documented. Then mark of identification is very, very important. We document at least 2 marks of identification, any scar or mole in obvious part, body parts. Left thumb impression is also to be taken. Then the points which are relevant in history are, of course, the onset of menarche, yes or no. If yes, what is the age of onset of menarche? What is the menstrual history? Her last menstrual period, whether she is menstruating at the time of incident, whether menstruation is occurring at the time of examination, was the survivor pregnant at the time of incident? If yes, what was the duration of pregnancy in weeks? Any history of contraceptive use? If yes, then we have to document the method of contraception. And of course, vaccination status like tetanus or hepatitis B also needs to be mentioned. Then we have to document in detail about the history of sexual violence, the date of incident being reported, the time of incident, the location, the estimated duration, whether it is 1 to 7 days or 1 to 2 weeks, 6 months, whether it is a multiple episode or 1 episode, or it has been a chronic thing for lasting more than 6 months. What were the number of assailants, name, sex of the assailant, approximate age, and if known relationship to the survivor. As Lakshmi ma'am was telling, most often the assailant is known relationship of the survivor. Then description of the incident in the words of narrator. This is very important that we document the history of the sexual violence in the words of the narrator. And narrator of the incident can be survivor herself or himself, or can be an informant. And when it is informant, we have to mention the name and relationship to the survivor, and we have to add as many pages as required to narrate the story. Then point 15b is type of physical violence used, if any, like if she has been hit with hand, fist, blunt object, sharp object. So this is just a checklist, and we have to put a tick mark over there. Then any kind of emotional abuse, like cursing, violating, terrorizing, use of restraints, use or threatened the use of weapon, objects, etc. Then verbal threats, example, threats of killing or hurting the survivor or any other person she knows, and sometimes blackmailing with the use of photographs, luring by sweets, chocolates, drinks, drugs, money, etc., or any other thing has to be documented. Then any history of the drug or alcohol intoxication, whether she was sleeping or unconscious at the time of incident. If survivor has left any mark of injury on the assailant, that detail is also to be taken, because survivor often in self-defense can leave mark on the assailant. Then the details regarding the sexual violence has to be mentioned like this. As already discussed by Lakshmi madam, it is not only the penetration by the penis, it could be any object, it could be other body parts. So we have to mention, was the penetration by penis or any body part of the self or assailant, like finger or tongue or any other, or was it any foreign object? And where was this penetration used, whether in the vagina, urethra, anus, or mouth? So it is in such a detail that we have to document all these things. Then we have to also record the details regarding sexual violence in the form of any oral sex by assailant, yes, no, or don't know, post masturbation of self by the survivor, post-masturbation of silent by the survivor or manipulation of genitals, exhibitionism, did ejaculation occur outside the body orifice, whether it was in mouth, anus, or urethra. And for everything, there is yes, no, or don't know. If yes, ejaculation occurred. If yes, which part of the body, whether condom was used or not. If yes, what was the status of the condom? What was the lubricant used? If yes, describe the kind of the lubricant. If object was used, describe the object. Then we also have to mention about the post-incident detail, like whether survivor has changed her clothes, changed her undergarments, she has washed her clothes, she has taken bath, she has doused, she has passed urine and stool, and time since incident and other thing has to be documented. So, and any history of vaginal, anal, or rectal discharge prior to the sexual violence or after the sexual violence, and post-incidentally, whether she is having any symptom like painful urination, defecation, any fissure or pain in the genital or lower abdomen, these are to be documented. Then in general examination, of course, height, weight, general build, pulse rate, the vitals, respiratory rate, any other disability or deformity has to be documented. And then comes the important part, describing the injury on the body. So it has to be described what are the injuries, where are the injuries, and how are they. So what means whether they are bruises, nail abrasions, teeth bite, cuts, laceration, fracture, tenderness, boils, and where it is located on the scalp, face, neck, shoulders, breast, wrist, forearms, thighs, buttocks. And of course, we have to describe the size of any abrasion or laceration present, the color, the swelling. And then of course, we know that these injury can range from complete absence of the injury to grievous injury. So we have to document in detail. And then we have to examine the external genitalia always, in addition to the obvious injury. And that includes the examination of the labia majora, minora, urethral meatus, fourchette, perineum, and hymen. Per speculum, very important is this, that per speculum and per vaginal examination should not be done unless it is required for the detection of injury or for medical treatment. And of course, we have to examine the anus and rectum for any bleeding, tear, discharge, edema or tenderness, oral cavity for any bleeding, discharge, tear, edema or tenderness. Then, of course, systemic examination is to be done, including the detailed abdominal examination. And then comes the evidence collection or sample collection. This is very important to obtain the confirmation of allegation, to establish the link between victim and scene, and to establish the link between victim and the assailant. Every contact leaves a trace. So evidence collection, we have to identify we have to maintain the chain of evidence, identify the specimen, label the specimen, sign the label, and record. So what are the sample collections and investigations we have to do for a hospital laboratory? It is blood for HIV, VDRL, Australia antigen and HCV, that is serology, urine test for pregnancy, ultrasound for pregnancy and internal injury, X-ray for injury. Then we have to collect sample to be sent to the straight forensic laboratory. And this is to be done in debris collection paper, clothing evidence wherever available to be packed in separate paper bags after air drying. So all these protocols has to be followed and it is to be handed over to the police. So what are the samples we have to collect? We have to collect swab from any stain on the body, like blood, serum or any foreign body, scalp hair 10 to 15 strands, head hair combing, nail scraping is to be collected from both hands separately, oral swabs, blood for grouping and testing for drug alcohol, blood for DNA analysis, urine drug testing, any other object like tampon or sanitary napkin or condom object. If we are not collecting, we have to mention the reason for not collecting. Then genital and anal evidence, each sample to be packed and labeled separately to be placed in a bag. So we have to collect any evidence. If there is any evidence of matted pubic hair, it is to be collected. Pubic hair combing, if shaving is done, we have to mention that it cannot be collected because of the shaving. Cutting of pubic hair, mention if shaved, 2 vulval swabs. We have to collect, one is semen and another for DNA, 2 vaginal swab, 2 anal swab, vaginal smear air dried for semen examination, urethral swab, and samples to be preserved as directed till handing over to the police, along with duly tested sample seal. And then we have to provide a provisional medical opinion, like I have examined so-and-so, aged so-and-so. We have to mention about the type of sexual violences and circumstances, the number of hours after the incidents have passed, after whether she has taken baths or she has used douching. Then we have to document my finding are as follows. What are the samples we have collected for forensic laboratory? Of course, the reports will be awaited. Samples collected for hospital laboratory, clinical findings, additional observations. And then, of course, treatment, we have to provide STI prevention, emergency contraception, wound treatment, tetanus prophylaxis, post-exposure prophylaxis for HIV, counseling, and other things as and when required. Like we also get cases sometimes of perineal injury, bleeding. So, of course, those kind of surgical treatment also required. Then we have to mention about the date and time of completion of the examination. That this reports, and it is to be mentioned that this report contains dash number of seats and dash number of envelopes, and then signature of the examining doctor, name of the examining doctor, and seal of the place. And then final opinion has to come in the form of different things, like there is evidence of recent sexual intercourse when recent injury is found and motile spermatozoa recovered from vagina or anus or rectum. Then it could be a remote sexual intercourse when partially healed injuries are identified with no evidence of motile spermatozoa. Then it could be a recent penetration when local recent injury, in remote sexual intercourse, yes, non-motile spermatozoa are found. In recent penetration, local recent injury is found in anus, vulva, or in the oral cavity. Spermatozoa are not recognized. Then there could be evidence of remote penetration when local partially healed injuries are present and no spermatozoa are recorded. Then it could be evidence of recent sexual assault when we get recent injury or bite marks over the different body parts. But any evidence of actual penetration occurring is not present. Then it could be evidence of remote sexual assault when partially healed injuries are present, but any evidence of injury to the genitals are absent. And there could be no evidence of vaginal penetration, but possibility cannot be ruled out when there are no injury and no spermatozoa can be recovered from vagina. So there are different kind of sexual assault which can occur. It is not only sexual intercourse, it could be penetration, it could be just a sexual assault in the form of injuries. And then there is evidence of recent, similarly, there could be evidence of recent oral or anal intercourse when recent injuries are present in the oral or anal area and motile spermatozoa recovered. There is evidence of remote oral or anal intercourse when partially healed injuries are present in these areas and non-motile spermatozoa recovered from these areas. Then there could be evidence of recent or remote oral or anal penetration when recent or partially healed injuries are present over there or over these parts, but spermatozoa are recovered. And there is no evidence of oral or anal penetration, but possibility cannot be ruled out when there is no injury and spermatozoa cannot be recovered. And then findings in support of the above opinion, taking into account the clinical examination finding and laboratory reports of dash, the identification mark described above, hours and days after incidents of sexual violence, I am of opinion that this is the final opinion. And again, we have to put the signature of the examining doctor, name of the examining doctor, place, seal. And it is very important that the copy of entire medical report must be given to the survivor free of cost immediately. One copy of the this opinion has to be handed over to the survivor. To summarize, of course, whenever a survivor comes to us, we have to take informed consent, take a detailed history, do the examination, including the injury, examination of the external genitalia. We have to document the injury. We have to collect so many samples. There are so many protocols, so many swabs to be collected. And of course, some samples has to be sent to the forensic laboratory, some to the hospital laboratory, and after collecting the report, we are supposed to give the final opinion. So again, this is the component of the comprehensive health care for in case of sexual violence, and this should be carried out in all cases. So we have to take consent, and we should not forget to provide first aid first before just going into taking history and examination and evidence collection. Evidence has to be sent in dry pack, sealed, handed over to the police, and then we have to document everything. We have to do the treatment part as well. We have to discharge and do the follow-up. So this is the Annexure 1 that shows the sexual assault forensic examination kit. There are fixtures in the form of examination table, light, curtains, table, chair, various equipments, what are the drugs which are required, and what are the documents we required. Everything is present in this kit, and this is often available in the forensic department. As Sarita Madam was telling, AIMS has got a very good forensic department where these are available, but in my institute it is not so much updated yet. And these are the supplies for collection of forensic evidence: the sterile gauze swabs, microscope, slides, a sterile urine specimen container, plastic specimen bags, spatula, so many things. So all they come in a concise packs. So this was what I was talking about. This should be available either in the gynae department or in the forensic department. It is better that it is available in the forensic department, and we can always help them in doing the examination part and treatment part. So thank you all. So that is all about. I'm thankful to the persons who have prepared this beautiful PowerPoint presentations. So that's all. Thank you.
Thank you so much, ma'am, for such an elaborative session. And
so Vasna Madam, your comments are most welcome on this, because I have so many queries.
Thank you, Archana ma'am. It was really not only enriching, also enlightening. It actually opened our minds, because the questionnaires that we prepare and we have in our domain are much simpler. So I was thinking that we can actually put certain elements of this and make our questionnaires a little more complete, so that the questions are much more sharper. Today morning I went to browse through the documents of MOHFW, so I was a little that time only I thought, and now your presentation was very comprehensive. I'm very thankful to you, and those things I was thinking, like informed consent and informed dissent, these things are things which should be at our fingertips, which help us to keep ourselves safe and then render our duties towards the victims. So that is very important. And secondly, it is very important that we want conviction rates to be more than double at this stage, because we find problems in reporting. You find social stereotypes where they do not report, or the survivors, their safety is at stake. They are financially dependent on people that they do not want to come forward and report. These are some problems that we face always. People do not know the broadened definitions of rape. They think that only one particular kind of penetration is rape. So there are many things which actually are not very good, because the first thing is that retributive justice is important, because unless and until the conviction rates are more, at least in my domain, we cannot say that some proper justice is done to the people. There is something in gender justice. So I am very thankful, particularly the forensic aspect. This is very important for policing. We already are into trainings in policing also. Now we have taken into proper trainings, we liaison with the forensic laboratories, and we also undergo e-forensics or forensic trainings. So I am very grateful. And then we express our heartfelt gratitude to Dr. Lakshmi ma'am and Dr. Archana ma'am for these 2 sessions with us, and on issues of gender stereotypes and how we can break these gender stereotypes. We are thankful as AIMS fraternity. We are thankful to you. We convey our best wishes to you and congratulate you on your achievements in general, and particularly that you could spare so much of your time for us and give us this enriching experience. Over to Sarita ma'am for a general acknowledgement of.
I'm just looking at Dr. Lakshmi Srikhande. She is nodding the neck and she wants to say something. Madam?
No. I am just wanted to praise you, Sarita. Well conducted and fantastic audience. And I'm sure everyone has gained from this 2-hour session, because this is really a passionate, not only for Dr. Shanta, who is our Foxy president, but I think each and every woman, we all are passionate. And what Upasna is saying, yes, we have to work hand in hand to increase the conviction rate. It is really very sad feeling when the perpetrators, they go scot-free. So it's a very good initiative on the part of Foxy and very good on the part of Sarita to bring it to Raipur for the sensitization of all our members. Great job, Sarita.
So I must thank to all being here. I just want to conclude about this Dheera session. We learned right from the beginning that what is the violence, what is the need of obstetrician should know about this violence, and then what comes under the violence, what is the assault, and how to examine a survivor. So the best part I learned from Dr. Archana Kumari is that when you're doing a survivor of this sexual assault, it is not simply the reading of the incident report brought by the police. You yourself has to make the report. What happened, how happened, because it is going to help you out in giving you a final opinion. Then the examination should be very thorough examination, a very systematic examination, and which material to be collected, when and how it should be preserved. There are very much clear guidelines. You can just put on net website and it is there. And I just come across the AIMS Delhi. They have a very good booklet on the examination of the survivors of the sexual assault, even for the POXO candidates also. So I think in the AIMS Raipur also will be having such sort of booklet which will make all beginners to understand that thing. Now, Dr. Archana, I have some questions. I have been worked in the State Medical College. I have worked in the peripheral hospital. Now I am in the very high referral institute. See, what I have seen when we write the opinion. When we write the opinion, we simply write no definite. Dr. Chandrasekhar, can you mute yourself? Dr. Chandrasekhar, please mute yourself. So mostly what we do, we simply write no definite opinion can be given regarding this recent sexual intercourse. And I was very happy to see in your 12 to 15 point, this comment was not there in the opinion part. But our report goes like that. That is, we have to accept the thing.
Most of the time, the report is like the possibility of rape cannot be ruled out.
It is very rarely written, And the second thing, what I wanted to the lacuna in the reporting format, all the reports are based upon that, whether the spermatozoa were present, dead or mobile. See, we at our center are not testing for the presence or absence of the spermatozoa. So if I'm an examiner, if I go to the court of the law, then I will look at that what is the report of the forensic laboratory on the samples which I have collected. And based upon my initial reports and analyzing this lab report, I'm going to give the final report. So whatever I'm submitting at the time of examination, I'm just submitting the a temporary report. So these 12 points may be a bit difficult for us to write. Therefore, we usually write no definite opinion can be given, because definite opinion is based upon your spermatozoa, which is being
most of the time we don't get a spermatozoa because usually the survivor come very late to us.
So that is again, we are mentioning the duration of the incident. So we should never miss this thing. If it is there, that's fine. Even in the absence of spermatozoa, then based upon the other incidents reporting and all the circumstantial evidence, the things can come out. And that is the law part of the judiciary and the advocates. But what I'm talking about at my level, if I'm going to present a report in the court of the law, what is my initial report and what is a forensic laboratory report? Based upon that, I'm going to make a report, my statement on the court of the law. It happens when you go into the court, then they give you the file to read. They give you the forensic laboratory reports available to you to read. If you don't get, you have all right reserved till the report is not there. I cannot give my final comment what happened to this case. So that is what I think we have to be very honest in preparing the report if you really want to save our women. Otherwise, every time it will happen, the things will happen. They will have an harassment, reporting to the police, filing the FIR, going to the court repeatedly, hiring the law, doing so, wasting such a money. At the end, they're not to come out with nothing. Just based upon the reports, what is we are making. So I think we need to be very honest when we are making the report. So with this comment, thank you so much, all these speakers. Yeah.
Case you were mentioning, a 13-year-old girl came with a severe perineal injury, bleeding. So that kind of evidence is itself suggestive that, of course, sexual violence has occurred.
So that is very rare. In POXO, it is not very difficult to prove. But when they are more than POXO, 18 years ke baad, it is not only married women. Even you get and having the relationship nowadays, it is very common. That's why the hymen condition being withdrawn for the reporting part now.
What I mean to say, when there is evidence of injury to such an extent, it is straight away an evidence that sexual assault has occurred.
Dr. Archana, when I face in the court of the law, they say, if I'm telling it is a penile injury, they say, is it a hard and blunt object can cause this injury? If she has put on a stick of such a wider thing, can it cause this injury? Yes, why not? Yes. This is happening, you know.
It's very difficult to, of course, stand in the court actually.
That's what I have attended more than 100 cases of 376 in the court of the law, and I know every text and bit how the advocates of the prosecution and the people they defend themselves, and then you have to stand out with what you have written in your report. So I think we should never be like when you're making the report, you are also in the medical college, I'm also in the medical college. We should be very honest and write everything what you got on the report. That is very important to be done. Anybody, Dr. Nandini is there, and Dr. Padmaja, Dr. Lakshmi, Dr. Prema, all the speakers are there till end. I'm so happy to see you all. If anybody wants to make a final comment, please, you're most welcome, and then we'll end the session.
Thank you, Dr. Sarita, for including me in this. I learned more than I gave to the lecture, because as Dr. Lakshmi was telling, I'm in the private practice, so I have a very small thing, and I'm in the fertility issue. So we have even less this thing. We see the emotional trauma of women. We don't really see these physical abuses, but it has been an eye-opener, and thank you for including me.
Madam, the last question I wanted to ask again. Suppose somebody, I am saying that some woman has been physically abused, sexually or physically, and if she doesn't want to report, but she may turn up on later date after 1 month, 2 months. So should we have a record like photography or videography, so that it may become a potential medico-legal case, so that I should have a record?
Photography and videography is not allowed, but you can have an injury report written on the paper, because you cannot do photography and any videography without the permission.
Yeah,
so that is very important.
Yeah, ma'am, can we take the permission of the patient?
No, you cannot ask for the consent. And these are people who don't want to report. They will never give you the consent for everything. You know, this privacy is very important. So that is up to,
Actually, I am asking this question because 1 month back, we operated upon a case of gossipy woman. Some gauze was inside, and the left inside was some other doctor. Then our HOD forensic said that you take the consent of photography and videography, and you just do it, because some people, the doctor who has left that gauze will say that it is not came out of your abdomen. It is another gauze and you are showing it.
See, what is the thing for that? On such cases, you have to send whatever you got for the pathology for the
Okay,
reporting, and
yeah,
the
yeah, yeah.
pathology report will tell what it is. You cannot take the photography.
But
But if
okay,
it is in a police case, already reported case, then you have to do everything. But if it is
Okay,
not a reported case, you have to
Okay.
take the consent of the
but
patient.
after 1 month, injury will be gone and everything will be gone. That's why I was asking.
So your descriptions will be such beautiful. You can make
Okay,
the
ma'am.
diagrams in your case sheet and keep everything ready. So in
Okay.
future, if it comes, maybe the case comes after years together, you know, you forget about everything. You
Okay,
left
then-
that center also,
Okay,
and then the inquiry comes to you. So, and
So
then
they will
can
not be
look-
asking, the judge or judiciary will not be asking for photographic evidence at all. Okay.
No,
Okay. ma'am.
and you can deny you did not take it because it was not a police case. I was just treating that patient and I have taken. It's like
Okay,
that.
ma'am. Okay, ma'am.
So am I right, Mrs. Upasana, madam, on this, what I'm talking about?
Yeah, ma'am, you are absolutely right. Sir. You are absolutely right. Sir.
So the police is not going to grab us, no, if you don't do that, please.
Oh, no.
So I got a license from you. Thank you so much.
Videography and photography also needs, in certain cases, in certain aspects, it needs the permission of the magistrate, first of all. And then the scene of crime, preservation of records, if those things are done already, videography is done, then there is no need on your part to do the videography.
Okay, ma'am.
It's once again a very sacrosanct thing considered, because videography in itself is not a piece of substantive evidence. So that would not help.
Actually, madam, after 6 months, they are going to ask that there is no evidence. You have drawn this diagram, falsely drawn this diagram. There is no evidence. So this kind of case, okay.
I have one thing to suggest, sir. Lately, you asked one question. How can we track the complaints, or how can we track what is going on in the cases? There is something called CCTNS, crime and criminal tracking network system.
Okay, ma'am.
So that is a broader platform where you can check the status of the cases. And within that, we have something called NBSO and IPPSO for sexual offenses particularly. So if you ping there, if you write anything there, then we are bound by, the cops are bound by their duties. They'll have to submit the report. They'll have to keep the charge sheet or FR, whatever it is.
Okay.
So thank you so much all. And then I will invite Mrs. Rohisha to propose a vote of thanks. And Dr. Meera Baghel, are you there? Because you told you're going to comment at the end of the session. Meera madam, are you there? So I think she's not there. So Mrs. Rohisha, please, you are invited for proposing vote of thanks. Mrs. Rohisha is a lecturer in the College of the Nursing.
Thank you, ma'am. Am I audible, ma'am?
Yeah, you're very much audible. Go ahead, please.
So on the behalf of the organizing team, it's my privilege to propose a vote of thanks for this event. And I should thank Sarita ma'am. This sessions was so interactive, and the experience the eminent speakers have shared have really was an eye-opening to us and our students also. And we thank the distinguished guests, Dr. Shantakumari ma'am, President Foxy, and Dr. Madhuri Patel ma'am, Secretary General Foxy, who have taken initiative to organize this webinar as part of the Dheera initiative and joined with us to share their valuable thoughts and knowledge. Thank you so much, ma'am. I would like to express our profound gratitude to our honorable guest, Dr. Meera Baghel, CMHO Raipur, and Dr. Ajay Bharadwaj, who is with us and graced the occasion with their presence and words. Thank you, ma'am and sir. And I would also thank our respected director, sir, Professor Dr. Nitin Nagarkar, sir, for his constant support and guidance. Thank you, sir. And I extend my gratitude to Professor Dr. Sarita Agarwal, HOD, Department of Obstetric and Gynecology, AIIMS, Raipur, because with her motivation and engagement have made this program a successful event. Thank you so much, ma'am. I must express my deeper sense of appreciation to Dr. Binu Matthew, ma'am, Principal, College of Nursing, AIIMS, Raipur, and ma'am have given the support and guidance for us in organizing this program successfully from here. And I extend my sincere thanks to all the distinguished speakers and respected chairpersons of today. You really made the day, and you are very experienced professionals who have shared your knowledge with us. Thank you so much. I extend my gratitude to all the participants, faculty, staffs, and students who are highly motivated and whose participation made this event a successful one. And I also thank the a team behind this program who are very motivated and dedicated, including the colleagues, office staffs, IT department, and other members of the organization team. I really congratulate them and express my sincere thanks to the entire team for the success of this program. And thank you, Sarita ma'am, for giving me this opportunity. And once again, I reiterate my thanks to all. Thank you, ma'am.
So thank you, Mrs. Oisha, for sharing my responsibility of proposing of the thank, which is the most difficult part. So thanks to all once again. And thank you the faculties and all the nursing college. Prema Priya, I can see is still moving. Thank you so much. Your voice is very sweet. Dr. Nandini, Dr. Lakshmi, Dr. Chandrasekhar, all, Mrs. Upasana, really. Thank you so much all being there. And I think we have almost 70 delegates still join with the session, and we have the seminar rooms, nursing college students also. So with this, we can end the session. Thank you and bye-bye. I think we will meet again. So
the Dheera feedback form link is there. So all the other delegates, please click on the link and fill it right now. It hardly takes a minute. Thank you and bye-bye.
Thank you so much.
Thank you.
So all please, this is very important. Once you will fill up the feedback form, then only you will be getting the certificate. So please do the feedback form. Thank you so much to all.
Thank
Shriman,
you,
you can
ma'am.
just end the meeting, huh? Thank you so much.
Okay, ma'am.
Thank you.
Welcome, ma'am.
Organizer,